Welcome, everyone. Thank you for joining us for the Y90 Masterclass this morning. We are pasting some notes about the technology in the chat to help you get oriented. Just a quick hint, you can open the participant list by clicking on the participant icon in the Zoom toolbar. And this will help you see who all is on the call with us today. I'd like to invite you to update your name in the participant list using the instructions in the chat if you would like. You might add your organization or your location to your screen name. We will have SIO staff in the audience and they will put 2 asterisks after their name so you can identify them. We are monitoring the chat, but feel free to unmute yourself from time to time during Q&A. We'd like this to be as interactive an experience as possible. If you're having any technology challenges, look for an SIO staff member. I just want to take a minute to discuss the educational learning objectives and CME information for this course. Our faculty and program committee is Dr. Riyad Salem, Dr. Daniel Brown, and Donna D'Souza are our co-chairs. We do have a complete list of invited faculty on the SAO Central page for you to review. So this is the educational learning objectives. Again, all of this is on the website if you'd like to review it more thoroughly. This course is accredited with the ACCME for 11 AMA PRA Category 1 credits. And we've also been approved by ABMS for MOC Part 2 for radiology. So at the conclusion of this course, you'll be sent a post-test and evaluation form. For the CME, you will have your certificate available for download immediately. You will be self-reporting your MOC with the ABMS. Before I introduce our first topic, I want to invite you again to submit questions at any time in the chat box, as well as your comments, takeaways, anything you found useful, and any general feedback. We'll do our best to come back again and again to the questions to help shape the conversation today. Thank you for taking the time to review my housekeeping notes. It's now my pleasure to introduce the SIO Masterclass Program Committee Chair, Dr. Salem.
Thanks, Dina. I appreciate it. And I'm delighted to be here with all of you guys. It's nice to see everyone's faces this morning, wherever in the world you may be. I see some people from Turkey and everywhere, so it's really nice to have everyone here. I assume everybody can hear, otherwise I'm sure we will get some messages. And before we get started, I do want to thank Certex for the educational grant to the SIO for completing this. There's a lot of interesting information with Y90 over the last 5 to 10 years, which I think is the impetus for a course like this. There are always a lot of new tips and tricks and nuances that I think we all want to share with everyone. And I think these types of courses are always very helpful. These courses and these sessions are only fun when we discuss, we debate, we agree, we disagree, because this is meant to be a course where we all learn from each other and everybody's experiences and everybody's practices can be shared and we can learn from everyone. So I really want to ask people to participate as much as possible in this, and hope to have sort of lively discussion. Save your spicy questions for the tumor board if you want, or for the Q&A session, but we really want this to be interactive. And I think HCC in particular is one that is very conducive to that. The design of the course, as you probably saw, is based on probably the 4 most common things you will see: the HCC, cholangiocarcinoma, colorectal cancer, and neuroendocrine. There's obviously a liver met session as well, but I think most of the big tumors that you're going to deal with are covered here, and that's why we like sort of the design of this this type of course. If there is some time between the lectures, we may get some Q&A in there. I'll take sort of chairman's discretion to see how that goes. Everybody has 15 or 20 minutes, depending on their assigned time. But before I get started, at least on my session, I'd like to ask for the polling question to be up. These polling questions will be used to guide Q&A and to get some more discussion. So the first polling question, ladies and gentlemen, please, is which do you typically treat more frequently with Y90 in your practice? HCC or METS or both? So are you primarily an HCC shop, a METS shop, or both? We'll wait 30 seconds for everybody to answer, unless Kristen tells me to move forward. So you can tell me if we've got a lot of respondents.
Okay, I'm going to go ahead and end this first poll. It looks like the majority of you have responded. I'll go ahead and share these results with you all so we can see where we stand.
Wow. Third. Very interesting. So this will spark some interesting discussion. I'm surprised by these numbers, but also very excited about these numbers. So I think this will spark some good discussion. Okay, guys, so I'm going to get started and sort of introduce where Y90 fits in. And what I want to provide for you in the next 15 minutes or so are things you want to be thinking about as you go through this course, areas of controversy and places that I think are good discussion points. So to remind everyone, Y90 in general is a microembolic therapy, and that is the rationale for it being utilized on an outpatient basis, and it not having the classic post-embolization syndrome that you might see with the more classical embolic therapies. And talking first about HCC, I want everyone to recognize that while we all apply the BCLC algorithm, recognize that everything on the left-hand side of the BCLC algorithm is not based on randomized evidence. So while we all try to get level 1 evidence, these recommendations here are based on level 2 non-RCTs. On the other hand, the chemoembolization, the systemic therapy options are in fact level 1 evidence. So keep that in mind when you're trying to build your argument and look at papers and publications when influencing sort of your decision-making process in tumor board. Years ago, there were several phase 2 studies that were published that really validated the reproducibility of the use of Y90 in HCC nationally and internationally. And so I think that narrative has now been dealt with, and everybody is reproducing the data and in fact getting better and better data as we go along. But to start with HCC and highlight sort of, to me, the 3 most important treatment areas that I think are of interest in HCC. And the first one is the radiation segmentectomy. That is that you can apply a very high dose of radiation in a very small spot. And I think Bill Rilling and others will be talking about that this afternoon. So ablative radiotherapy using the transarterial route. And the one nuance I want to highlight for everyone and why the radiation segmentectomy makes sense is because as you treat the angiosome, you're able to target the microsatellites that develop around tumors as they get larger. And that's why the local recurrence rate with radiation segmentectomy in HCC is very low, because you're dealing with the microsatellites. And that's one of the failure points of ablation. And so this is an example of a radiation segmentectomy. You can see this with a good response, and you can see the necrosis and the radiation effect. And you show that exactly the radiation is targeted in the liver and nowhere else. And that's really what you want to do. And you have a good response here after one segmental radioembolization. Here's another example of a dome lesion. I think that's a difficult lesion to ablate. It's right underneath the heart. But if you catheterize that segment, notice that you have your angiosome, you're dealing with microsatellites, and that is what the ablative radiotherapy concept is all about. Don't forget the use of cone beam. I think that'll be highlighted during the 2-day course. But notice that we're doing a rad seg here and a lesion right underneath the heart. And this is the pre-treatment scan, the 1-month scan, and the 2-year scan. Completely ablated lesion, very easy catheterization, a much more challenging ablation, in my opinion, in a lesion in that area. The next concept is radiation lobectomy. Radiation lobectomy is the idea that you convert someone that is initially unresectable in HCC to resectability. And what is the most common reason why you might see that? Well, resectable patients are Child-Pugh A, as you know. You do not resect Child-Pugh Bs or Cs, but most commonly the FLR is too small in that patient. So the idea here is that you're going to treat the tumor, but also radiate that entire right lobe to atrophy the right, hypertrophy the left, in preparation for radiation lobectomy. Here's an example of a large right lobe tumor that you can see here. And this is the left lobe. It is cirrhotic liver. But as you treat the right lobe, notice the atrophy, hypertrophy complex. And the volume has gone from 500 on the left-hand side to 776. So the FLR has hypertrophied significantly. One of the things that I think will come up during today's discussion is portal vein embolization and HCC. And I think we need to recognize the strength or weaknesses of the PVE literature in HCC. And one of the things that is lacking is a time-dependent volume analysis. As we all know, most of the PVE literature is you do a PVE, you get a 1 month or a 6-week scan, and you decide if it's hypertrophied. And one of the things that we've done here in HCC is generated a time-dependent analysis of the left lobe volume as it increases with time. And simultaneously, the tumor is treated. Here is the tumor volume decreases right here. You can see this. And of course, the right lobe parenchyma will atrophy. So this is the atrophy-hypertrophy complex, giving you an increase in FLR in a slower time, but ability to treat the disease as well. And again, radiation lobectomy has also been demonstrated and validated in multiple international settings, as you can see here, where the contralateral lobe will hypertrophy, the ipsilateral radiated lobe will atrophy. So very, very important. What does a radiation lobectomy liver look like? You can see right here, multiple tumors that have been treated, and the left segment 2-3 is clean of disease and hypertrophied, and this person is undergoing a right trisegmentectomy. Now, one nuance with HCC and Y90 has to do with the application of portal vein, in the application of patients with portal vein thrombosis. You obviously cannot do a PVE in someone with portal vein thrombosis, but you can do a radiation lobectomy. This is a infiltrative HCC with a good response here, with a major hypertrophy on the left. And this person had demonstrated good tumor biology with a hypertrophy from 30 to 68%. We bring him back to tumor board, and he goes to the operating room and has a right triseg. So in a patient with portal vein thrombosis, it is even possible to apply radiation lobectomy and even cure them with resection. This person is now alive 5 years after a radiation lobectomy in a scenario of portal vein thrombosis. Something else you'll hear today from Shui and others, it has to do with same-day radioembolization. Can we minimize the number of trips for the patients and do all this in 1 day? And this is early proof of concept study that we published with a median room time of just over 2 hours. So you can really do this. But one of the things that we are working on is the concept of the 1 hour Y90. What does that mean? The 1 hour Y90 has to do with what we do now in the same day paradigm. As you know, patients come in, they then go, we perform an angiogram, we inject the MAA, they go to nuclear medicine, and they come back and get the Y90. This is the same day concept. But if you can eliminate the lung shunt study, you might even be able to perform this in 1 hour with no lung shunt study. What is the concept? This is something we just published a few months ago, the concept of eliminating the lung shunt study for small tumors. If you look at your data, most of you guys, you will see that your small tumors do not shunt. And so is there a real necessity for the lung shunt study when you have small tumors? And this is evidence that we showed here that if a person does not have a TIPS, for some reason, TIPS causes increased lung shunt study. But if you don't have a TIPS, you do not need to perform a lung shunt study and are able to apply up to 600 gray in that segment without influence of any risk of lung dose. The worst case scenario in this case is 14 gray. So just proof of concept, but something that I think we will be investigating in the future. Level of evidence is important in HCC. There's a small randomized trial showing that Y90 outperforms chemoembolization. This is conventional TACE with statistical significance and a very impressive hazard ratio of 0.12 when you compare by time to progression. And 2 clinical trials here randomizing Y90 to sorafenib that failed to meet the survival endpoint, but I interpret these 2 studies clinically as positive clinical trials. We can discuss that during the Q&A. If you are a statistical purist, this is statistically negative, but from a practical standpoint, the overall survival curves overlap, and and we've seen this and validated this in multiple settings. So we can bring this up during the Q&A session that I think these are in fact positive clinical trials, not negative clinical trials, given the limitations of the studies themselves. It's possible to think about Y90 as a potential curative setting. This is something published in Radiology a few years ago. median survival 7 years for solitary tumors, no different than you might see in surgical resection or ablation and even liver transplantation. I know Rohan will be speaking later on, but I know that liver transplantation following Y90 has been a point of contention. And can you actually do this without significant injury? And this is data that we just published showing good long-term survival in patients that were bridged with Y90. This is 15-year follow-up in a 207 patient clinical cohort. So just to sum up a little bit on the HCC and where it fits in our setting, it is our treatment of choice, arterial treatment of choice applied with curative intent. In small lesions, you can bridge, you can palliate PVT, and even downstage BCLC-D patients to liver transplantation. Alex will be talking about immunotherapy in HCC later on, but here's a great case that we had of combined Y90 immunotherapy. This is pretty impressive. And so this is something that we'll probably be writing up. But this person, in fact, had metastases, extrahepatic metastases at baseline. After Y90 immunotherapy, the metastases disappeared. He had this, a small recurrence was resected, and is doing well 3 years later. Let's go on to liver metastases real briefly and highlight things that I think you want to be thinking about while you hear the other speakers tomorrow on neuroendocrine and colorectal cancer. The first thing is, metastatic lesions are hyper, not hypovascular. We describe them as hypovascular because of delayed venous scans, but if you perform a CT angiogram or a cone beam CT, these lesions that are described as hypovascular are in fact hypervascular, and that's why you see good response to Y90. So think about level of vascularity. Now, this may change with things like Avastin and other agents, but they are hypervascular, not as much as other ones, but they are clearly not completely hypovascular. And here's another example from my friend Lawrence Bester in Australia, hypervascular colorectal liver metastases. For context, I just wanted to show this paper. This is an early Andy Kennedy paper, because 15 years ago when we started performing Y90 for colorectal cancer, patients had only had oxaliplatin and 5-FU, and now the field has changed so much that Y90 is being relegated to later and later stages. Clearly, we are seeing that. This is an example of a patient that we treated years ago with biliary obstruction with a good response with metastatic colorectal cancer. The person had had infusional 5-FU and Y90. PET scan is still very common in the colorectal cancer patient population, so be on the lookout for that when you assess response in colorectal cancer. We know that response rate goes down significantly as more lines of therapy are applied. We used to get patients here in this area. We are now getting patients here, if not even more beyond. So I'll be interested in the discussion later on what we are seeing with colorectal cancer, and response rate, again, continues to decline. Nevertheless, in the salvage setting, depending on how early you're getting your patient, the median survival is anywhere between 6 and 15 months. The best study, of course, is the combination study here that was published in Lancet Oncology, looking at combining Y90 and resin microspheres in the first line. Again, no change in overall survival. This was a negative trial, but response and hepatic progression-free survival did favor Y90. So it did show the antitumoral effect, and I think there's evidence here that you can use some of this evidence to think about using this in, for example, patients that are being bridged or downstaged to resection instead of or in combination with portal vein embolization. So there are a lot of issues with colorectal cancer, and I'll be interested in tomorrow's sessions with Dan on where Y90 fits in colorectal cancer. But in my practice, it is being pushed back further and further. Briefly on neuroendocrine tumor metastases, also a paper from Andy Kennedy early on showing very high response rate with Y90. We know that neuroendocrine tumors are very hypervascular. So we know that they should get a response, and it looks something like this. Large lesion here with an excellent response after one treatment, and multifocal bilobar disease, excellent response. There's a whole session on this tomorrow on neuroendocrine. Cholangiocarcinoma, I think, is probably the one condition where there's going to start to be in the Y90 space just as much interest and research as the HCC space. Obviously, you want to recognize how you classify cholangiocarcinoma. Most of the ones that we treat are peripheral mass-like cholangiocarcinomas, not the infiltrative or the ductal cholangiocarcinomas. There's a lot of data and evidence now in this area, And I think it's going to be very, very interesting over the next several years on us studying the role of Y90 in cholangiocarcinoma. My intent with cholangio is to make a patient resectable. The only way to cure them, this is a cholangiocarcinoma here around the IVC that we downstaged with selective Y90 that you can see here, and the person underwent a trisegmentectomy out 5 years. That is the intent with cholangiocarcinoma. Another example here, large tumor. This is a classic appearance of cholangiocarcinoma, the scalloped appearance here. This person required Y90 to treat the tumor and portal vein embolization with a great hypertrophy, and the person underwent a right trisegmentectomy. So I do think there's going to be a lot of new work now that's going to be done in cholangiocarcinoma, and this will be discussed a little bit this afternoon and tomorrow on Y90 and cholangiocarcinoma. So to conclude, where does Y90 fit in, and what are the sorts of things that you want to be thinking about during the next 2 days? For us, we apply Y90 as our arterial treatment of choice across all stages of BCLC. And there's obviously going to be a lot of discussion on immunotherapies and Y90 and systemic therapy, and I think Alex will touch on that later on. Colorectal cancer in our practice is being pushed further and further back, and we really only have salvage settings, but I think there's a lot of interest in looking at this in the portal vein embolization setting. And then, of course, neuroendocrine with large tumors that you can see here. And of course, cholangiocarcinoma. I think there's going to be a lot of interest. So welcome everyone to the SIO Masterclass. There's going to be a lot of interesting topics. I appreciate the opportunity to chair this. And we're now going to go on to our next session. So I'd like to ask the next polling question, please. The next polling question asks, over the last 5 years, is your Y90 practice increasing, decreasing, or staying the same?
Okay, I'll give you about 10 more seconds to get your responses in. All right, and there are your results.
Increasing 65, decreasing, staying the same. So most people's practices are increasing. So this is interesting. Again, we'll keep that in mind and have a discussion during the Q&A session, and of course the tumor board. So it's now my pleasure to introduce Dr. Armin Mavash, who's professor of interventional radiology at University of Texas MD Anderson Cancer Center. We'll be discussing the evolution of a Y90 program, a 15-year experience. Armin.
Good morning, Ria. Thank you very much. Let me just try to share the screen and make sure it's working here. Can you guys see this?
Yep.
Let's see if I can get this to you. There we go. Okay, so thanks everybody. I just wanted to thank everybody for attending. I know it's a tough time for everybody. I'm going to talk about our experience here. I started almost 15 years ago, and kind of where the program started and where we are now. I think we've made lots of progress, and it's kind of an example of a program that has progressed over time. So this is just my disclosures. So there's lots of people that helped me along the way. First and foremost is Ravi Murthy. Riyadh and Ravi go back a long time. They were the first group of people that actually did Y90 in the US way back in the early 2000s. And he's very instrumental to our success. Mike Wallace obviously was our chairman and very helpful in the progress of our program. And Chenu Kapadath is my current kind of focal collaborator. He's speaking a little bit later, and he's a nuke med physicist, and it's been an incredibly rewarding experience to collaborate with him. And then we have a big team of a dedicated team of IR and nuclear medicine in terms of the scheduling and techs and nurses and everything else that works with us. So kind of where do we start back in, where do we start our Y90 program at Anderson? Well, Dr. Murthy came to Anderson in 2002 from University of Maryland, and he was doing Y90 there for a couple of years, kind of essentially where Y90, one of the places Y90 started in the US. And when he came, he was the sole user of Y90. And he did use both devices. At the time, the reality was that because the glass device required the protocol and he was like the only user, we ended up not using that. He didn't use the device. So we ended up kind of abandoning it after a couple of years. So when I was a fellow in 2005, 2006, the only device we were using at the time was the resin microsphere. I joined the faculty after my fellowship here, and then Dr. Avature also joined at the same time in 2006. So we essentially had one experienced user and 2 brand new users, but our volume was low, so we had time to learn. So I think that was key to our program. And so how did we, and this is just a kind of a caricature of us, because we were, Dr. Murthy was our mentor, and then myself and Ronnie kind of learned from him as we were going along. So how we were going to learn, I think that was the key to our success. What we did and what we set up is that we actually started by having a weekly conference. I think that was very important for us, because both of us being novices, we needed the direction of somebody more experienced. So basically the 3 faculty and then fellows would join us. We would present every Y90 case that had been, diagnostics and treatments. And then we did have SPECT CT at the time, and the tech and had SPECT CTs, and we did Bremsstrahlung SPECT CT, even though they weren't quantitative at the time, they were qualitative. And then we would review their treatments at 3 months to see what would happen. And I think it was for me, obviously as very junior faculty, it was very, educational for me, because it was, you got to see everyone's cases, and then we would kind of see what were the outcomes. So that was incredibly important. And obviously having post-procedure imaging, even way back then, was incredibly helpful for us. That helped us learn from our mistakes and experiences, and this worked well, this did not work well. So that honestly for us, even back in 2006, was very, very helpful. So what did we do to kind of improve our clinical exposure? Because at first it was just Dr. Murthy by himself. So we decided to start attending multiple tumor boards, and Anderson has like 20 tumor boards a week. So there is a liver tumor board. There was also a colorectal tumor board and neuroendocrine tumor board. Those were the areas we kind of focused. So we kind of would go out and attend these weekly tumor boards, because when you're at the table, that's when people are going to ask you, what can you do and what are your options? And then clearly you just, especially when you're very junior, you need to, get your name out and people, face to face know who you are. So once we were there, people would ask us and we'd kind of give options, and we did honestly try to grow the Y90 program at that time. I got to say, something that was incredibly helpful for us is that we created a calendar, like an Outlook calendar back then, and it was all manually entered. It was kind of painful, but you would enter the day you did the diagnostic, day you did the treatment, and then what their first follow-up was, so that you would actually know at the time they came back for their first follow-up scan that they were coming back tomorrow. So you would look and see the images before you would go see the clinician, and you could actually email the clinician and say, this is what I think happened, this is what we should do next. That was, I think, very important for us at that time, to kind of be ahead of the curve and not wait for the patient to be in clinic, seeing the clinician, and then the clinician calling you and say, hey, what do you think about this? We were trying to be proactive and know that they were coming. And that is, as painful as it was, I think it was very helpful. We did have a dedicated IR clinic at the time, so we could see our patients in clinic. And then we actually, very helpful, got dedicated IRPAs, which would follow our patients with us. So they were kind of part of this kind of program that we worked together. So what are the things that we learned in this we did this for about 3 or 4 years. So we looked at kind of the qualitative SPECT MA versus SPECT Y90, which they may or may not, actually match each other. And a lot of this, we look back and we realized some of those things had to do with our personal techniques. Like we weren't as meticulous as maybe we thought we were, honestly. And so that's the reality. So we did look at, response in areas of uptake that you could see on the qualitative imaging. And so you could see if we had no uptake at all in the area of the tumor on the post-administration SPECT, and we realized these patients didn't respond. So there could be technical issues, or maybe the tumors were just so hypovascular you didn't get any activity in there. But that was also a learning experience for us. We did create a automated system for follow-up after a couple of years with our homegrown EHR. And then slowly over time, we did increase our volume from about 15 per year to about 75 cases per year over about 3 years. We did use a lot of cone beam CT for planning. Mike Wallace at the time was like a champion of cone beam CT, came out with one of the first papers of how cone beam CT changed treatment planning. And so that was incredibly important for us. Back then, cone beam CT was incredibly slow. I mean, it would take 20 minutes to reconstruct the images, but they were incredibly helpful in terms of confirming that you were treating the tumor adequately, and in terms of looking at volumes and looking at, adequate perfusion. And we would look at the cone beam CTs and kind of compare them to the SPECT CTs. And, I had this idea, maybe we could use cone beam CT as a pseudo surrogate for vascular enhancement on SPECT versus SPECT CT. So this is just the paper. This is one of the first papers that came out when I was, right as I finished my fellowship. became an attending, they looked at the interventions that, were affected by cone beam CT. And I think it was incredibly important because essentially in about 20% of patients, it changed the management of the patient. In addition to about 40% of the patients, you actually learned something you didn't know. So I think it was incredibly important kind of paradigm shift for everybody. That cone beam CT was incredibly useful for doing any liver-directed therapy. This is a case that Dr. Murthy published around the same time or very soon after. Patient with metastatic melanoma and metastatic ocular melanoma who had multiple transarterial therapies. And on cone beam CT, you see that there's a rim of non-perfused liver, which was incredibly interesting because you never see this on a two-dimensional angiogram. It's just impossible. On the SPECT CT, you can clearly see that there is uptake, obviously in the area of vascularity, and essentially lack of uptake in the periphery that had no essentially had no uptake, no perfusion on the cone beam CT. And then you can see the pre and post Y90 PET. Sorry, this is an actual PET CT. This is a pre Y90 PET CT on the top and then a post Y90. And clearly he had a response in the area that got the Y90, but he clearly had no response in the areas that didn't get Y90. So that was very important for us to kind of look. We need to focus on where it's getting treated and what's getting perfused when we're doing our treatments. On the meantime, we did this kind of odd thing where we did this our first case we ever did it. We put a balloon in the common hepatic artery to reverse the flow of all the hepatoenteric collaterals. And so what you can do is if you have little tiny vessels like this and you cannot embolize, you can reverse the flow with a small balloon catheter. It's like at the time we used a 7 French balloon catheter. Now we just use a Fogarty. That was our first case back in 2010. And now we've done it with over 100 patients. And it's kind of a little kind of a gimmicky thing, but it's very useful not to have to embolize, and especially embolize things you can't get to. And this was her post just showing that there's no activity in the area that used to have activity. So we did an interesting, this is something for me when I was saying cone beam CT, can it be a surrogate for SPECT CT? We did a phantom study looking at the uptake between cone beam CT and true enhancement. And so we did find a correlation. If you do a non-contrast cone beam CT followed by a contrast enhanced cone beam CT, there is a direct correlation between enhancement and cone beam CT. The issue that we had in clinical practice, to be honest with you, is that the streak artifact in a cone beam CT at the time causes a great deal of heterogeneity in the essentially enhancement. And so we now have a dual-headed injector, and now that I think we're going to use that to kind of quantify cone beam CT as a way for people to use. We have a prospective clinical trial, and we're actually using cone beam CT. How good of a surrogate is it than the SPECT CT? So what are the things that we do now? Essentially, we stopped doing our weekly meetings, honestly, after about 3 or 4 years, basically because I got married and had kids, and my wife said you can't stay late, for 2 hours every Wednesday evening. So, and we obviously had a certain level of experience at that point, but we still had these questions: what are the doses that we need for tumor response? What are the doses we cause liver toxicity? And then we need some quantified images, and then kind of what cases are ideal and non-ideal. So we did at this time, or very soon after, Dr. Capdeath and our group started working together, and this helped us, and I'll kind of go through that in a second. So we did create an automated email via our EHR, and now it's actually incorporated into our Epic. So Epic can kick you an email back as soon as your patients, and I think people can look into this at their own sites if you have Epic. They will send you an email when your patient comes back for any follow-up imaging after you've done, say, a Y90 procedure or a TACE or whatever. And so I will get this email as soon as the patient gets some cross-sectional imaging, and then I can look at the images and then call or email the clinician before the patient even gets to their clinic. So a lot of times sometimes the images aren't even interpreted when the patients are in clinic, and sometimes you disagree with the interpretation. So I think that's been very helpful for us, knowing that the patients are coming instead of following them manually. The other thing is that we did reintroduce glass microspheres in 2010 and started doing some, treating HCC only on the indication only with glass microspheres. So we do have now an automated email service that goes through Epic, and it's obviously feasible. It's just some kind of Epic plugin that was created by the Epic team. And so you might look into it at your own sites. I think it's been very important because every time a patient comes back, we get an email saying your patient got an imaging study today. And now you can look at it and then call the clinician. I had an issue on Tuesday, actually, of this week. The patient had come back to clinic and the images had not been interpreted. So the clinician wasn't sure what to do, but I had actually reviewed the images prior to the clinic and saying the patient had, no progression, no new disease. And so at least it helped the clinician in clinic have an answer before, the imaging report came out, which ended up coming out after the clinic visit wasn't so helpful. It does happen that our interpretation is different than the imaging report. I think it's very important for you to kind of proactively follow your patients and look at the imaging and look at the reports. And then sometimes, you have to go back and forth with the interpreting diagnostic radiologist about this, the findings. So one thing that we thought was that we needed to improve our understanding of dosimetry. And clearly with a nuclear medicine physicist that joined Anderson was Chenu Kapadath, who's speaking a little bit later. We started looking into that. That was my question, even as a fellow, when I asked Dr. Murthy in 2005, hey, how do you know how much dose this tumor got? And he said, we don't know that. So obviously that's an important, point for us, is knowing the dose that the tumor gets and the dose the normal liver gets. And we've obviously done a lot on that in that vein over the years. So we did start a project. We looked at different software platforms. We have MIM now at Anderson, but they're all very useful. I don't want to tout one piece of software over the other, but we do use MIM because that's what Anderson has already for nuclear medicine. And we actually began a project contouring all our HCC and neuroendocrine tumor patients, which was very helpful for us. We came out with a couple of different things we did over the last few years. I was lucky enough to become the PI of the EPOC, the Theraspheres for colorectal study. That was a big learning experience for me. I became the PI and then actually got a medical oncologist to become a co-PI. And that was I think collaborating with your oncology team, incredibly useful, creates relationships. And, these things continue on beyond, studies, but clearly collaborating. We've done a bunch of different studies and looking from a science physics standpoint and also clinical. I think kind of a big thing for us was looking at dose response Y90 with glass, looking at dose to tumor, dose to normal liver. That really helped us a great deal for us in terms of moving our practice forward. And we've done lots of other work with Chenu and his group, looking at dose to lung, et cetera. And I think it's been a very fruitful collaboration with us in nuclear medicine and physics, which we're very blessed to have, a dedicated physicist to work with us. This is an important curve for us when we were doing this, looking at the non-responders versus responders, and kind of this is a dose response curve that we created from our data, and then kind of toxicity based on dose to the normal liver. And this has been key for us in terms of how we are kind of moving our practice forward. And so what we did is we created a regular meeting with nuclear medicine, IR faculty and staff to look through workflow issues, looking at projects we can do together, looking at studies that were coming up or studies that we're doing, and then any practice changes we want to do based on our new data, and looking at future projects. So clearly collaborating with the nuke med department definitely has helped the workflow because our volume has increased. We're probably up to from, originally 15 to 75. Now we're at about 125 cases or more a year. We have a lot of younger faculty that are, very eager. So, they're trying to attract other procedure types or case types, tumor types. So we did collaborate with nuclear medicine a couple of years ago, starting this same day in-room Y90 project. And we've treated about 40 patients, not nearly as much as say Riyadh and other groups have, but it's been very, very a great experience for us thus far, doing same day in-room Y90 diagnostic and treatments. We do have a current prospective Y90 dosimetry trial and using MAA for surrogate, using really detailed angiography technique. And we've, about 1/4 of the way enrolled. So we're very excited about that. I think we'll learn a lot. And we've learned a lot already. There's lots of details that you learn when you do a prospective clinical trial that you have to record all the issues that you have. Right now, when we have new faculty, we have 7 currently doing Y90, and each faculty is onboarded by a senior faculty. So you spend time with that person, going through the literature, going through cases with them, and you actually come and scrub in with them to help them on their first several cases, kind of going through treatment plans. We train them on MIM, and then we're always available for questions and assistance. So I think for us in general, the keys to our success was, first of all, we collaborated, the three of us initially collaborated within our department. We then started collaborating with all the referring MDs, nuclear medicine as well. We clearly have to mentor the new faculty so that they all work together as a team, and that's been very important. Asking a lot of questions has been very key to our success, and we've developed other collaborations outside of Anderson as well. And the other thing for us was that we, a lot of time communicating with the referring physicians on HCC, colorectal, MNETs. And actually now we haven't done a lot of cholangio, but as Riyadh pointed out earlier, the GI Med Onc who does cholangio is now sending us some cholangio cases. So clearly that has helped. Again, it's all about relationship building. You got to be there, be a tumor board, participate, communicate well. So anyway, thanks for the opportunity. And if you have any email questions, you're welcome to email me.
Thank you very much. That's a great overview. I'm glad your program is doing so well. You guys have contributed a lot, to Y90. There is a polling question, our third one of the morning, and so I'd like to ask if we could get the polling question displayed. And the question is, are you performing Y90 in the outpatient setting? Yes or no? 44% yes. Wow. Okay, that's very, very interesting. Okay. So this will be a great point for discussion. So I would now like to introduce Dr. Sabina Amin, Interventional Radiology Division Head at Cooper University Healthcare. And Dr. Amin will be talking about building a Y90 practice outside of the ivory towers like MD Anderson. Sabina.
Hey guys, can you hear me?
Yep.
Hello. Okay, perfect. My name is Sabina. I am going to be discussing building a Y90 practice outside of the ivory towers. First thing, do your homework. So unlike residency or fellowship, the cases don't really land on your schedule magically. So the first thing you're going to need to do is your homework. What are the actual needs? If there isn't an established program, what are the needs of your patient base? What types of tumors do the majority of your patients have? And really, who controls the patient? If you want to start a program, you got to figure out who the key stakeholders are. So it's not usually who you think it is. You have to look at the administrators, finance, and the support staff who become incredibly important, such as your schedulers and your clinic staff. It's really important to make sure that you have all the necessary support along the way. Having candid conversations from the start regarding the intent to build the service and its initial time and resource requirements is really important, because if you don't have the support of your hospital and your group, the project is really, unfortunately, unlikely to succeed. You're going to need to get buy-in. So to the administration, it might mean bringing, quote, the cutting edge, even though it's been around for a bit, to the masses, if they haven't been doing it already. For finance, unfortunately, sometimes you have to spend money to make money. And don't forget about the downstream revenue that comes from clinic visits, follow-up visits, and really the drive into the post scans and the follow-up scans. When we first started, finance said we were allowed to have about 2 administrations a month, which in reality, once you've done training, is not what we're used to, but you have to start somewhere. The other thing you want to really look at is your support staff. So your clinic staff and your schedulers, who become incredibly vital to the entire operation. And your oncologist. Is there already an established multidisciplinary tumor board? And who sees the patients you want? So make sure to meet with your GI docs and your med oncs. They're frequently the first to see new liver masses, not just then in the setting of cirrhosis, but also in newly diagnosed metastatic disease. Unfortunately, you're not in Kansas anymore. So sometimes there aren't patients to get to. There's not dedicated tumor boards. There's not 4 tumor boards for every liver disease process. You might not have everything you want. So if you wait for it all to be perfect, you might be waiting for a while. You have to figure out who are your authorized users. Sometimes it's not the interventional radiologist, and you have to play nice in the sandbox. It might be rad-onc, and it might be nuclear medicine. Really, you want to befriend your radiation safety officer and really figure out the politics. Involve your hospital's radiation safety officer as soon as possible in the process. He or she will need to be familiar with the regulatory issues surrounding arterial administration of the isotopes. Cone beam CT. I wish I had it, and when I first started, I did not. So old machines, unfortunately, can't and won't give you a cone beam. I mean, it may take 10 minutes to get one spin, which means it's not really going to work out. Fact of the matter is, you'll get amazing at catheterizing the gastric arteries because you'll be able to tell where the right gastric comes from if you get into it. All of the toys in residency and fellowship in the ivory towers, there's so many catheters and wires and all the fancy things you can use, but it costs money to have all these fancy things, and you might not have it right off the bat. Dosimetry, you might have to do it on your own, so they don't come with their dose assigned to them. You might need to recruit help. So seek help from the industry and your former training programs in getting these protocols. They might be able to give you formulas and dictation templates, and you can use DAVR and SMAC, which I'm sure we'll get into in a little bit. PET CT or even SPECT CT, fuzzy science can actually be a real thing. Don't overlook the role of nuke med in this process. Protocols should be in place to ensure that the process is standardized and there's no staff confusion. You're going to want to establish additional protocols for liver shunt calculations and Bremster lung scanning in your nuke med department if they don't already exist. But you probably have everything you need. The patients are there. You likely have all the basic catheters and wires you need. You have all the coils, nuke is usually around, and you have your rep and DAVR and SMAC. Industry reps generally have a wealth of experience and resources, especially in marketing and educating your target referrers. This is another area where they're indispensable. They can give you the peer-reviewed journal articles and the patient pamphlets that you need to distribute, as well as help you form this continuing medical education events with national and regional experts if your teams are not going to listen to you. These events not only give you a chance to discuss treatments that you offer, but also provide you with extended face time and can help with establishing stronger relationships with your referrers. And it takes a lot of patience to build a program. If you have a waiting room, you will have patients. Not really true. Unfortunately, you have to sometimes recruit your patients, and that sometimes involves the grassroots aspect of it, the patients themselves, and tumor boards. If they're not already there, then form the tumor groups, but don't be the diagnostic doctor as well as the IR doctor. You really want to be viewed as the consultant. This paradigm shift has really already occurred in almost every academic center, but sometimes it's slower to change in the community practice setting for a variety of reasons. And then you're going to want to talk to your key players outside of tumor boards. So GI, hepatology, hem-onc, surg-onc, rad-onc, have regular phone conversations, add input at tumor boards, and accept ownership as a patient and your treatment. These are all key elements. And the everyday. You will be saying yes to a lot of biopsies and ports. They are the gateway. Many of us are asked to perform biopsies on unknown lesions. We're often the first to determine that an unknown liver lesion represents a cancer. So take this opportunity to get involved in the patient's care. It helps streamline the patient's care and build collaboration with the primary physician and really the oncologist. Tumor boards. Most community or pseudo-academic medical centers already have a tumor board in place. But if you can't speak their language, you will likely be sitting there silently. It's crucial to understand what is and what is not in the NCCN guidelines. They are considered the authority by which nearly all medical, radiation, and surg-oncs guide their decision-making. And when you're starting to build services, it's a good idea to start building services that are already widely accepted to have sufficient evidence to be incorporated into the NCCN guidelines. The oncologist soup. Know your chemo regimens, know the biologist, know the immunotherapy, and most importantly, know the difference. Most of the physicians that have recently trained have experience in this arena, but the new chemo regimens and guidelines are constantly being updated and should be on your regular reading list. Not only will it help you better understand where your therapies fit into the overall treatment guidelines, but it can help you avoid pitfalls such as performing angio on someone getting Avastin. Say yes to every single patient, but say yes to seeing the patient. If you don't have space, make this space. An essential component in the establishment of a clinical model is really seeing the patient and having clinic hours. You're going to need vitals, heights and weights, and a targeted physical exam. Even if you have to start seeing patients in consult between your daily IR cases, it'll go a long way in establishing yourself as a clinician among your peers and a valuable consultant to the med and surg groups. As you become busier, you might justify an entire clinic day dedicated to seeing those patients, but you sometimes have to start somewhere. And make sure to include everything in your H&P. The insurance companies really use them to say yes or no. Learn your spiel and train others too. The patients have already spent some time with Dr. Google and their oncologist, so know what you're going to say and rehearse it sometimes. Send a thank you note or a post-treatment letter. It's not always all about the patients. You sometimes also need to send some type of correspondence to your referent. And under-promise and over-deliver. Know the data, but don't always sell the earth, the moon, and the stars to everyone. But know when to say no, not right now. At the very beginning, you really want to establish a track record of safety and good outcomes. It's really hard to convince a skeptical surgeon or med-onc if you choose borderline patients who aren't going to do well after treatment. So cherry pick if you have the luxury at the beginning. But if it seems like what you're getting are patients who are poor candidates, still see the patient and communicate with the referring doctor. It can be used as a teaching moment. These are invaluable opportunities to describe your ideal patient and labs to the referring docs as you explain why this patient may not be the best candidate right now. And you won't always be as good as the ivory tower just yet. You're going to have to recruit your patients. They don't appear on your tables, either while you're seeing them for their report or their biopsy or during tumor board or pure marketing with the help of your group, hospital, or industry. The consult is your chance to establish a relationship with your patients and referents. Evaluate the patient beyond the chart review, either ECOG status, and become the patient's team doctor. The predetermination takes about 1 to 3 days to get off in most locations, so keep that in mind and let the patients know that there may be some delays in getting them scheduled right away. The map and treat. We do these in the same week. Sometimes we'll map on Monday and treat on Tuesday. You might want to leave the same day map treat to the pros for now, because when you're first establishing something, it can be a little bit of a bear with your schedulers to figure out. When you're first starting out, treating the next week isn't a horrible plan because it gets everyone on the same schedule at the same time. You're going to want to think about your discharge planning. You need to create a patient timeline for both your schedulers in the clinic and your procedure area. You're going to want to create a standardized post-treatment lab and consult algorithm to make sure that your patients aren't lost to follow-up, because that's going to become really important, and that they don't present to clinic without results or lab testing. So set expectations with the patients, have your team know if narcotics are going to be given out, talk to them about their imaging. Sometimes you will be the doc who orders the imaging when you need it, and then always make sure that you schedule them for follow-up visits. Thank you guys, and good luck.
Sabina, thank you very much. That's a great overview. I appreciate it. We're going to go right to the next speaker. It's a pleasure to introduce Eddie Saint-Amour, who will be discussing, who's an interventional radiologist at Cardi Cancer Center. He'll be talking about Y90 in the office-based setting. Eddie.
Thank you, Riyadh. Appreciate it. All right, so as Riyadh said, I'm Eddie Saint-Amour. I'll be discussing Y90 in the office-based setting. This is my disclosure. Now, this is where I practice in Little Rock, Arkansas. This is the Cardi Cancer Center. And as our CEO always explains, we aim to be the cancer destination in Arkansas. So just as a little reference, Cardi is a multidisciplinary oncology group all under one roof. Our Y90s are all performed in an approximately 5,000 square foot area on the first floor of the building, with a pre-op recovery area centered around all necessary imaging modalities to perform a mapping and dosing. This is our combined CT fluoro room, which we have found crucial to performing a broad range of procedures, not just Y90s, in limited space. So as you can imagine, we were able to do all our procedures in this room, from CT guided biopsies to angio and everything in between. So in 2017, the CPT code for OBL Y90 was first introduced. My partner at Cardi, David Hayes, was the first to complete an all OBL Y90. And as I'm sure most IR performed at the time, we had a more hands-off approach when we initially started our Y90 practice. We would see the patient in clinic. We would do a mapping with a planar scan the same day, usually do our dosing within 2 weeks, and then a second dose 4 to 6 weeks later if necessary. Almost all of our patients were a bilobar sequential treatment. We did all femoral access, and follow-up imaging and labs were typically left to the oncologist. So as you can see here, this is the first complete patient done in an OBL setting. This is a 78-year-old man with history of HCC. He's ECOG1 Child's PUA with a solitary liver lesion. I'll just show you that real quick. This was his pre-treatment scan. As you can see, he's got that solitary lesion in segment 6. And then on his dosing angio, I'll just show you the dosing. Post-delivery planar imaging. Again, the mapping images were essentially the same thing. So just as kind of a rehash, you got a pre-treatment scan that showed this lesion, 19 months post-treatment images during routine follow-up demonstrated that the lesion had essentially become necrotic. The patient actually died a few months after this last scan, just shy of 2 years from the treatment, but not from the tumor itself, but from a fall. Today, we're far more involved in our patient care. Our practice has changed substantially, much more so than a few years ago. We see the patient, they're presented in tumor board. We still perform our mapping the same way. We do the dosing within a week and get same day PET CT, so we can get dose volume histograms. We have a healthy mix of bilobar sequential, segmentectomy, and lobectomy treatments. We almost exclusively use distal radial access, and we also review all follow-up imaging with the patients themselves. So kind of as a similar case that we have recently done, this is a 65-year-old man with a history of HCC. He's also ECOG1 Child's PUA with a solitary liver lesion, as you can see right here. This is his angio and 4D CTA that we attained with our CT scan in our fluoro CT room. Kind of gives you an idea of what the distribution of where our beads are going to go. And then this is our post-delivery PET scan that we get instead of planar imaging now. And here you can see a good distribution of beads where the tumor is. And then in conjunction with the imaging, we have adopted tools that we feel add value to our service and could potentially alter a patient's treatment plan, as has been demonstrated in Asia, where they're using SBRT to touch up the edges. This dose volume histogram gives us a better understanding of how much dose was deposited in the tumor, gives us an idea how we might think the patient will do. And if you're in a practice like mine, it's important to know that it's also reimbursed. So as I was saying, we have evolved our practice to make ourselves more efficient and improve patient satisfaction. Do almost all exclusive distal radial access. That's one way we have adopted things to allow for easier patient recovery, and also minimizes the use of our recovery space. As you can see from this chart, we aren't the only facility to embrace OBL Y90s. There's been incredible growth in OBL Y90s since first performed in 2017. There were 3 performed in 2017, 80 performed in 2018, 210 performed in 2019, and 310 so far in 2020. I was only able to obtain the hospital outpatient data from 2018 and 2019 for comparison. Those are 2,905 in 2018 and 3,017 in 2019. However, they're expecting a drop in hospital outpatient volume in 2020, secondary to COVID, obviously. And then it's always important to talk about reimbursement. As you can see, OBL has pretty good reimbursement. And you might be saying to yourself, well, it looks like you get paid more for outpatient hospital, which is the middle column. However, you have to realize that the outpatient hospital has a higher overhead costs, and insurance companies are and will continue to look for ways to decrease costs. So OBL looks pretty good in comparison. Then you might be saying to yourself, but ASC pays less. However, in both the ASC and outpatient hospital, you have to factor in supplies, drugs, professional fees, So these prices can really bump up what you're seeing here on this, and especially if you think about coils, which can be very expensive. But in an OBL, the physician essentially assumes the burden of cost control, and hence the insurance themselves can contain the cost in an OBL with a global fee, which they know exactly what they're going to pay every time. Now, overall data on OBL procedures is limited, but that which is available is certainly encouraging. This is one of the earliest papers on OBL specific findings, which demonstrated OBL procedures to be both safe, effective, and satisfactory to patients. This is the first paper dedicated to Y90 in the OBL setting that was just published in the September issue of JVIR. This paper demonstrates that OBL Y90 is both feasible and more efficient than hospital Y90s. So in conclusion, OBL Y90 is feasible, safe, efficient, reimburses well, and patients like it. This is clearly shown with the remarkable growth in OBL Y90 since first performed in 2017. And ultimately, it is important to note that you will most likely evolve your practice over time as we have, leading to a very robust Y90 program.
Thank you, Eddie. Thanks for that presentation. Out of curiosity, do you think the office-based setting has increased your volume? Is that in itself a factor, do you think, or?
Well, I think a few things have been instrumental specifically for us. One, that we have an in-house referral system. So, like I said, we have everyone under the same roof. We all have a joint tumor board together. And we even have clinicians out in the community that join our community board. So we're able to get referrals through them as well. But a big part also of what changed our practice was just reimbursement changes. So initially Medicare was the only insurance that would pay for it. But as we collected more patients, we were able to give private insurance companies the data on how well our patients have done. They've kind of opened up and have been much more willing to pay, so that at this point we have every public and private payer, except for Medicaid, which only pay in the hospital setting, and Blue Cross Blue Shield of Arkansas. Those are the only two insurances that won't pay for it in the OBL right now.
Thanks, Eddie. So we're gonna move on to the next and keep some of these questions for the Q&A later on. So it's now a pleasure to introduce Dr. Shui Ganjuli, who's Chief of IR at Boston Medical Center. And Shui will be talking about innovations in Y90 delivery.
Thank you. Yeah, so I'm going to talk about just some of the newer things that I'm doing in my practice. Hopefully you all can hear me. And I appreciate that we can still share, our ideas in this time of a pandemic. So thank you everyone for putting this together, SIO and Certex for sponsoring it. My disclosures. So I'm just going to highlight a couple things that I've kind of incorporated in my practice more recently. Transradial access, pressure-mediated delivery, we've kind of alluded to same week or same day Y90 map treat programs. And I'm going to highlight the new delivery system, Ceros from Certex. We've been talking about other things. When we're talking about delivery here, it's basically actually, giving the spheres and the process of that. And we just heard about office-based Y90. We have a lot more sphere activity flexibility and vial ordering flexibility. And for those of us that have been doing this for a couple of years, it's really, these things have really given us a lot of flexibility in treating our patients and help us build our programs. So transradial access really came from our cardiology counterparts, and it's well established now in coronary angiography and interventions. And one thing we can say from the cardiac literature as well as the IR literature now is that transradial access is really preferred over transfemoral by the patients. There are decreased access site complications, decreased post-procedure recovery, and you can immediately post-procedure ambulate. And so when it comes to like radioembolization or even liver-directed therapies in general, there's some beneficial things here. We're doing multiple angiograms, multiple interventions, so it gives us another site for access. These are outpatient procedures. I leave my TR band up for about 45 minutes and take it down. And so patients are, if you're not doing post-procedure imaging, they can leave the department almost immediately. So it really helps with the throughput of the patients. Now, there are some downsides when it comes to radial access with Y90. Asymptomatic radial artery occlusions, this is a real thing. I saw this more when I started radial artery access. I think it's very important to have a clean access, not cause a dissection at all. And since we're not really giving blood thinners like the way cardiologists do, we can take the TR band down quicker. So these are things I kind of changed. I've seen less radial artery occlusions since then. And even when it is occluded, you can still access and use it as an access site. We're doing a Barbeau test, so they're asymptomatic, but you should be aware of these. There's some papers coming out in the IR literature about access site complications, transfemoral versus transradial. In cardiology, it's clear from their literature that transradial has less complications. The IR literature is a little mixed. Maybe we're a little bit better at transfemoral than cardiologists, who knows. You can't necessarily say that, but I think they're pretty comparable. There is the theoretical stroke risk because you are going across the great vessels. I've had it once in my practice too, so you don't want to minimize this, but it is a possibility. Our equipment is getting better. I think the companies are supporting it. They know we're doing more transradial access for mesenteric interventions, so longer sheaths, more catheter options are coming. But the big thing, to highlight is we really should be doing cone beam CT with intraarterial therapies, and so with the arm bored out, it becomes an issue. And so I do mapping and treatment with transradial access. So I'm just going to highlight how I'm doing my cone beam CTs now with radial access. So you can put the arm across the body at the right groin. So this is really good for your room setup because our rooms are set up for right groin access. And there's some things you can use because the arm doesn't want to sit there necessarily to keep it in place. There's things like these finger holders that you can then secure, or even arm boards like this, and you bring it down to the right groin and you work from the right side. This is from one of my friends, Ari Sachs, how they've used some foam and arm restraint to really position the arm in place. And again, you can access and work everything from the right side. And I do this, and I have done this, but I will show this one case where this was actually the second 5 French Serra catheter I'd put in, and I caused this loop to occur. The first one I was able to disengage and pull out. Second one, this is what happened, and I feel like some of it was because of the arm, all the angles with the arm, and there's probably tortuosity of the vessels also. So what I ended up doing, I tried to pull this catheter out, and it wouldn't reduce, and the patient started having pain. You can see it's here in the brachial artery. So just how we got it out is we got femoral access, got a snare up, and then grabbed the catheter, and then we were able to actually reduce that loop and pull it out. So this is about my practice now is that I actually start the procedure with the arm out. We're using the left arm, and of course we don't go across all the great vessels. And I do all my mesenteric angiograms with the arm out. And then when I want to get into the liver, this is where I need to do cone beam CT. I actually bring the arm in. If the person's small, you can actually just bring it to the side, and the cone beam arc will be fine. Or you can actually put it up on the patient. I'll use a strap and kind of secure it. And then actually, I have no problem doing microcatheter work in the liver with the arm in this position. And you can give your Y90, your MA, and distribution. You have no problem with cone beam. And the companies are aware that we're going to be needing this. And so this is from Siemens, and they're already thinking about ways that you can do cone beam without having to bring the arm in. And I think as we come along, I think more and more people are doing radial, and we're doing cone beam. This is going to be part of our workflow, hopefully, that we don't have to do these kind of maneuvers. And when you're moving the catheter, bringing the arm in, the microcatheter does move, so you kind of want to watch under fluoro. But whatever you do with your team, the more you do it, the better you get at it. So really just pick something with your team, and that is your techs and your nurses, and it becomes quicker the more you do something. All right, I'm just going to shift to pressure-mediated delivery. So, there's a hot topic in IR. There's catheters being developed. There's balloon occlusion catheters, or catheters with these valves on them. And, what the theory that it's trying to get over is that tumors have leaky blood vessels in them and increased interstitial pressure. And what we've been relying on for decades with our embolic therapies is the blood flow to these hypervascular tumors. But if the pressure in the tumor is high, the theory is whatever we deliver can't get into the tumor, really can't penetrate it. And so people are working on things and trying to prove that by manipulating this tumor liver microvasculature, we can have better outcomes. And, I'm not know if I'm the most bought into this per se, but I would say I have been experimenting with some of these catheters, and you can find places that you might find it better. You do angiograms with it up or down, or with the valve, and you may see better uptake. And so I think it's something to experiment with. I wouldn't say it's do it in every case, but And the other thing is you can use it for reflux protection. Sometimes I worry about reflux of when I'm using larger activities, and so sometimes I'm using it for this. So I'll just highlight 2 cases here. This was a patient who had a remote liver transplant like 10 years previously, and unfortunately now develops infiltrative HCC of the left lobe. You can see it there with the arrows, and there's even some portal vein invasion here, but really hard to see the borders of these, and these usually don't have a very good outcome when we call them infiltrative HCC. And again, the cone beam CT again showing most of the left lobe. And so the thought was to do like a lobectomy here, and I wanted to inject a larger amount of activity and also more particles, but I didn't want to reflux it into the right side, given this is a liver transplant, and preserve that side. And so, this is a transplant artery, and we were able to thread this balloon occlusion catheter all the way out, and you can barely see the balloon. The balloon is inflated there. And at this point, we were able to give, without any concern of reflux, about 52.8 millicuries of resin for a radiation lobectomy. And then this was the follow-up. You can see we really had a good outcome, and she's actually had 2 follow-ups since then, which have been good so far. So again, just kind of experimenting with these balloon occlusion catheters. And here's another one, actually from my colleagues, Dr. Wernberg-Klee. Caudate HCC may be a little bit difficult for ablation. And these caudate lesions where the arteries come from can be variable, can be small, and it actually came off this left hepatic artery. There was a very small vessel there. And we really wanted to just get radiation into that tumor. We were worried about possibly accessing this or dissecting it. And so what we did was put a sheath here in the hepatic, in the celiac access, and we put 2 microcatheters in, and then you can see, you don't really see the tumor here when you're injecting the left hepatic artery, but when we put that balloon occlusion catheter up, now we see it light up. And so we were able to preserve that distal segment 4 and left lobe, and we gave 26 millicuries of glass. It was a recent case. We don't have follow-up yet, but we were happy with that treatment. So again, having these at your disposal, finding cases where they might help, I think for protection and also maybe uptake are interesting ideas. So we've been alluding to this in a couple of the previous talks, and I think the talk on creating a better practice or increasing your practice is really important to treat patients expeditiously. I think we did that, and we really saw our practice grow. And that doesn't mean they have to do same day or as we're going to talk about here, but really making sure that treatment and mapping are really tight. And I think 1 week apart is a good one. And again, the quicker you can do things, the more you can establish things, the better the throughput of patients. And so here's the current state for radioembolization. And Riyadh's group had done this with glass, same day Y90, and we did it at Mass General with resin. And basically what we're showing is that you can do same day Y90. It's feasible. We were able to treat all of our patients. We had similar outcomes, and patients were happy with that. What are the benefits? As I alluded to, treating faster, patient convenience. This is becoming less and less, but I think, as we started with Y90, oncologists, even patients felt it was a lengthy, complicated, costly procedure. And as we make things more streamlined, we decrease that myth. What are the downsides? Longer days for patients. And then the concern always is that your mapping may show that you can't use the Y90. And so far, we haven't had any problems with that. You can always deal with variant anatomy. You can split dose. You can do segmental infusions, maybe not treat as large of an area that you thought. And with lung shunts, unless they're really high, you can decrease the activity you're going to inject to make sure you're within the safe margin for lung dose. The big question is, do you get paid for both procedures? And we didn't necessarily prospectively look at this, but when we retrospectively looked at it, we actually were paid from some of our same-day Y90s for both procedures, and we sat down with our billers after too, and they said if you really document that the patient was left the room and these are separate procedures, you will get paid. I don't want you to say that. I don't want to say that all insurance companies will do this, but it is feasible. But if you're all of a sudden doing 40 mappings and treatments and you're only getting paid for 40 treatments, that is a consideration. Just some tips from our same day Y90. I think it's really important that you study the cross-sectional imaging in advance and you really plan the treatment out and your dosimetry before the day of. You really kind of know what you're going to do, and then you can always change the plan depending on what you see. we leave the we leave the vascular access in place, either femoral or radial. We just hook a flush bag up, and they go to nuclear medicine, and that was remarkably fast. I thought that would be the speed bump for our treatments, but they really wasn't. It was 20 minutes for a planar scan. We can do SPECT; it's a little longer, but really you can leave the room open for the patient if they go to nuclear medicine and back. And then you finalize the dosimetry at that point. I had planned out the dosimetry in advance, and we were drawing up the dose even before, but I think you should wait and see what you see on the angiogram, and then you can do it there. Or, I didn't do it with glass, but if you're ordering multiple vials at that point, you decide which vial you're going to use. Our average procedure time was about 4 hours, so it's not a whole day thing, and we weren't necessarily trying to be fast. And Riyad alluded to this. I think the more you do Y90, you kind of think a lot of these mappings are not necessarily required. It's just kind of an exercise. And they've already shown retrospectively that metastasis and early HCC have low lung shunt fractions. So maybe that's the future. I don't know what's going to take us to get to not having to do the mapping portion for some patients as a prospective study, but I think that may be the future. All right. Lastly, I just want to say talk about the SIO system. So we're talking about delivery here, and this is the TheraSphere box and the SurSphere box here on the right, and these plexiglass things that have a little, you have a checklist or something to figure out how to do it, and they're always kind of more complex and hadn't changed in 10 so years. And so Surtex took on this project and got some smart engineers here together in this picture, and this picture doesn't do justice to all the people that worked on this, but it was kind of interesting to talk about what all the problems were with the current delivery system, where were the leaks, the possible leaks, where were the issues, and really come up with a new system. And that was just recently rolled out. And it's the SIO system. And now you have this needleless vial, which is, it's drawn up and it's secured, so you don't have needles anymore. So where there are possibilities of leak, you don't have that anymore. And it's really very easy to set up now with just lure locks, and then there's actually the way they designed it. When you inject, there's kind of a vortex that occurs within the vial, and so you get more even distribution of the spheres. And it's again rolling out right now. And I know there's been a lot of people using it, and we've used it, and I think it's very smooth. It's making the delivery very easy, and I think it's another nice addition to what we do. So conclusion, I think. Transradial access is really nice, something to add. I know people really are very facile with femoral, but it just maybe can add something to your practice. And really important for us is just figure out how you're going to do cone beam CT. You don't want it to be a hindrance to you doing cone beam CT, doing radial access. So make sure you figure out a way to do it. And the more you do something, the better your team is at it. I think pressure-directed catheters are very interesting. Maybe find cases to utilize it. And as we were talking about, decrease the time between mapping. It doesn't have to be same day, even same week or 1 week apart. It really helps your practice grow. But know that if there's the right patient, you can do same day Y90. Thank you.
Thank you very much, Dr. Ganjuli. I think at this point, we'll take a brief 15-minute break. Thank you, everyone, for sharing your presentations this morning. Everyone can leave Zoom connected, or just reconnect with the same link at 9:45. In the meantime, please feel free to visit the Surtex virtual booth during the break. That link has been included in the chat box, and I'll look forward to seeing everyone in about 15 minutes. Welcome back, everyone. I hope everyone had a chance to stretch their legs. Thanks for returning so promptly. It's now my pleasure to introduce Dr. Donna D'Souza, Associate Professor of Radiology at the University of Minnesota, and she's the SIO Y90 Master Class Program Committee Co-Chair. And Dr. D'Souza will be introducing our next speaker. Dr. D'Souza?
Hi, everyone, and welcome back. Thanks for joining us. So it is my pleasure to introduce Dr. Chinu Kapadath, who is an associate professor at the University of Texas MD Anderson Cancer Center, and he is going to discuss with you radiation physics and Y90.
Great, thank you for that introduction. It's a pleasure to be here. So I want to start off by, thanking SIO and the organizing committee for the opportunity to speak to you this morning. Here are my disclosures and a brief outline of my lecture. So let's jump right in. When we talk of Y90, we use the word dose pretty loosely. And what I want to say is that the dose is a very ambiguous term. So we should start using proper language when we describe rate embolization. When we refer to dose, we actually meaning absorbed dose. And so the units of dose is normally rads or gray. But a lot of times we kind of are sloppy and we use it for activity. The right word for activity should be dosage, right? That is what is synonymous with activity. So we should say, I'm treating with 3 GBQ or 81 millicurie. So my recommendation is we should use activity for dosage, so say, activity of 3 GBQ and dose for absorbed dose. So treating to 100 gray. So what's important to note is that it's not appropriate to say I treat it with a dose of 50 GBQ. It's a dose of 200 gray or activity of 50 GBQ. So when we think of dose, we really have to think about the processes of interaction. So the collision loss of the electrons or the beta particles that come out of Y90 is really what is causing the radiation effect or the biological effect of absorbed dose. The electrons also undergo Bremsstrahlung radiation. This doesn't really impact dose in as much as it is used to assay the activity of the Y90. Okay. And when we talk of electrons going through a tissue, and I've shown a picture of a monoenergetic electron as it comes into water here, we see they do a random walk. There's a lot of straggling. So there is a cloud of dose that is deposited because these electrons move around. And the implication of that is shown here in the figure, where if I have an ideal distribution of activity, that is a square function, okay? This is a slice through a tumor, for example, that is uniformly perfused with Y90. The resulting dose is shown in red here, where activity at the very end, some of these electrons spill out. So this region is underdosed and this region gets a little excessive dose, okay? So it is something we need to keep in mind, especially when you're dealing with very high levels of radiation in the context of, let's say, radiation segmentectomy, where you really want to have good coverage of the tumor. What I've also shown is that the electrons have a range from Y90, and that the range of those electrons in tissue is about, maximum is about 11 millimeters, and the mean is about 2 to 4 millimeters, okay? However, when the electrons are in air, then they can travel a much higher distance, okay? So the mean is about 1 meter, and you can go up to 10 meters. So what does this mean? So from a practice point of view, when you're in the IR suite delivering radiation, as long as the activity is within the acrylic shield, you're fine. But when you start administering and it starts moving through the tube and exiting the box and then going into the patient, it is at that location, that transit time, where you can be exposed to high levels of electrons. So it is important to use an acrylic shield so you can protect yourself. So how do we measure Y90 activity? So the traditional way of measuring Y90 activity is, or any activities, you dunk in a dose calibrator, you press a button that is appropriate to that setting and gives the value. So one thing to note is that the Bremsstrahlung signal that is generated, that I mentioned is used by the dose calibrator, depends a lot on the geometry of the object, because that's how it is generated, and the containing material, because the Bremsstrahlung depends on the atomic number of the particle, of the nuclei. So as a consequence of this, we have two products here, one out of resin and one out of glass, and their form factors are different and their carrier shapes are different as well. So, not surprisingly, the dose calibrated setting for those two radionuclei, for those two devices, are quite different. So it is very important to make sure in the nuclear clinic that the right cal settings are used to measure the right dose. And then why am I angsting so much over how do we figure out what the dose is? Because the first step of dosimetry is to know how much you actually have delivered to the patient, right? So that is the first step. So here we have a treatment vial, and a treatment vial is either going to the patient or is going to be some part of a waste that is shown on the right here. We were interested in knowing what actually went to the patient. So that is the original vial minus the residual, right? We can put the original vial in the dose calibrator, but we cannot take all the residual in the tubing and stick that in the dose calibrator as well. So the way we normally approach this is we do a dose calibrator is basically an exposure rate meter, okay? It is just a very sensitive exposure meter, but the physics is the same. So the strategy that is used is we measure the original vial at a fixed distance and figure out what the exposure rate is. After procedure, we put all the waste in a jar, okay, put it in an acrylic shield and measure its exposure rate. And by looking at the ratio of those exposure rates, we get a sense of what is the fraction of activity that was delivered to the patient. And then we can take that fractional activity delivered and multiply that by the net activity in the original vial to estimate what was the activity that was actually delivered to the patient. So when we talk of radioembolization, okay, where does that fit in the whole context of radiation therapy? And it's important to know because we were talking about when you sit in a multidisciplinary board, we need to sit within we need to speak the language of medicine out there, right? So in external beam, in radiation therapy, we have external beam or proton therapy, and then we also have brachytherapy, right, where we use sources and we deliver radiation proximal to the tissue. Then when we talk of sort of radionuclide treatment, there are two types out here. We have internal with unsealed sources, and these are things that you've learned like radioactive iodine treatments, or for example, now the Lutathera treatments for neuroendocrine disease. And I would argue that the Y90 radioembolization sits within this paradigm of a targeted radionuclide therapy, although it has nice parallels with brachy. And I'm going to motivate it like this. When you look at a targeted radionuclide therapy, what we do is we administer a tracer drug, and then we do some sort of imaging of that tracer to see what is the biodistribution. Based on the biodistribution, we kind of figure out what is the uptake and clearance, and then there's a lot of modeling that goes into figure out how many disintegrations occur in the patient. And based on these disintegrations, we look up, what is the dose from one organ to the other, and we come up with these dose per administered activity for our target and organs at risk. And this is used to drive the administered activity dosage. But this is exactly what we do in the radioembolization. We administer MAA, we do single time point because this is a passively permanent implantation almost, right? Once it goes in there, it doesn't really disintegrate very quickly. We do a mapping of that. We assume no biologic clearance. Based on this, there are some equations of residence times we compute, and then we have S factor, which primarily is self-dose because Y90 is a pure beta emitter. And then based on this, we come up with dose per administered activity for a target. So we might here, for example, have the target is the liver or tumors in the liver, and the organs at risk might be the lungs here. And then based on these, we come up with the administered activity. So I would kind of posit that radioembolization is really targeted radionuclide therapy. So let's jump into a little concepts of dosimetry. And the reason I've written red in radioembolization here is that it is important to recognize it is the radiation that is causing cell death. It is not the embolization, okay? So this is not an embolic treatment as you're used to with other devices in your arsenal. But in radioembolization is a really radiation that is toxic. So Y90 being a pure beta emitter, all of the dose that is deposited is very local to it. And what I'm showing you is a dose profile of a point source of Y90 sitting right at the origin here. So you can see there's a beta dose here that is really dominating all the doses. The Brem dose is there beyond about 11 millimeters or so, but literally that is 6 orders of magnitude or greater lower than the beta dose at the center. So for all practical purposes, we can just ignore the photon component as to contributing any dose to the patient. So, so the dose to a tissue then becomes what is the activity in the tissue multiplied by this, what we call the self-dose factor, and divided by the mass in the tissue, right? Because in the end, dose is energy deposited per unit mass. So we need to have mass in it. So this, you get the familiar equations, right? So you get the liver dose is then activity, you account for the lung shunt, multiplied by 50, divided by the mass of the liver, and the lung dose accordingly, where you scale it by the lung shunt. So there's a couple of caveats we got to keep in mind here. First is that any error in the lung shunt estimate or organ mass propagates directly into errors in dose calculation. So if your mass estimate was off by 20%, then your liver dose is going to be off by 20%. Right? Conversely, if your lung shunt is off by 10%, then your estimates are going to be off. So it is very important to have these parameters as precisely as possible when we do dosimetry. And the second thing is that these models are giving you average dose of the target volume, and they're not telling you anything about the distribution. Okay, it's just an average dose, and they have some consequences that I explained here. Let's take a look at a simple thing as lung shunt fraction. If you look at the package insert of both devices, they say, oh, use, for example, a 1 kilogram lung mass for all patients. Here is a distribution of lung masses that we have computed based on CT imaging of about 50 patients, okay? And you can see that, well, here is the 1 kilogram lung mass that you're supposed to use for everybody, but there is a big spread of lung masses. And like I said, because the errors are proportional, if you use a 1 kilogram lung mass for all of these patients, you could have errors from 20% to 40% in your estimates of lung dose. And that is stemming purely from the estimation of lung mass. And a simple example to illustrate the limitation of mean dose. So here, if let's say you want to do a palliative treatment, whole liver, and you want to, let's say, target 100 gray. Okay, just a hypothetical example. So we've got a right lobe mass of 1,500 grams, a left lobe mass of 500 grams. So what you want is this scenario. So both the right and the left, they get a mean dose of 100. But for some reason, let's say all the activity went to the left lobe, right? The left lobe now actually has a dose of 400. The right lobe has 0 dose, but the total liver mean dose is still 100, okay? So this is still an accurate number, although in reality, it doesn't reflect what is happening. Vice versa, if everything went to the right lobe and nothing went to the left lobe, you'll see the right lobe got 133 gray and the left lobe got 0. Again, in this context, the mean dose is 100, but clearly there are differences between right and left. And what is the consequence of that? The spatial distribution of activity matters because it dictates a true distribution of those. And if you look at these 3 scenarios, we would not expect the same outcome, right? Based on the 3 different types of dose distribution, even though the mean dose is the same. So it's very critical to sort of assess post-therapy imaging, even if it's not quantitative, to qualitatively understand where was the dose distributed and was that what you intended for. Now I want to zoom into a much smaller scale of millimeters, okay? So you can see at the millimeter level, these microspheres are deposited very non-uniformly, okay? And they have in clusters as shown here, and they have different sizes. So the impact of this is that you have regions close to this location that are getting hundreds of gray, while regions a few, a millimeter or so away are getting much lower doses, okay? So on average, they may be getting high doses, but at the cellular level, some cells are really getting very high doses and some are getting low doses. So what is the impact of this? So if you think about radiobiology, we see that the liver is a parallel organ, okay? It is actually a radiosensitive organ, and we know from external beam, whole liver dose of about 30 gray is about the limit, okay? But the 30 gray limit of whole liver doses doesn't apply for radioembolization. And then why is that? Well, and that's what I'm trying to argue here is that it is the heterogeneous dose distribution that really is the factor that drives the differences, okay? Because they're heterogeneous, the amount of cell death between a uniformly distributed 30 gray and a heterogeneously distributed 30 gray are different, okay? So cell survival fractions are quite different. So what this implies is when you look at, for example, Sersphere versus Thelasphere, they each have different specific activities. So the normal dose limits for those 2 devices might be quite different. So at our institution, this is kind of our rule of thumb guidance to what is the normal liver can handle at the most, okay? So these are things one has to be aware of when we are dealing with the symmetry as well. A few other concepts to share with you. So far, we have been discussing everything in this uniform dosimetry pattern, right? I've been just lumping all of the tumors together and liver together. But in reality, we know they have different tumors here, they have different uptake, and so does the normal liver. And people recognized this a long time ago. In fact, Ho et al. In the mid-90s came up with this model called the partition model. They said, oh, this is pretty rudimentary. What we should at least do is to say, tumors got a higher level of Y90 compared to normal liver, because that's the intention. We want to actually treat the tumors, not the normal liver. So he came up with a model to say we need to have two things. We need to come up with what is a fraction of the tumor for the liver, and then what is the uptake ratio. So based on these two things, you can separately compute what is activity that went to the liver compartment and what is activity that went to the tumor compartment. Okay? And then you can plug those activities in with their respective mass organs to compute with the dose. So a couple of caveats note here is that if you have two tumors here, as I'm showing you, this is an HCC patient with a large anterior and a very small posterior. In the partition model, these both would be considered the same. Whereas in reality, if you look at the post-therapy imaging here, you can see the posterior lesion has much greater uptake than this large anterior tumor. Okay? So if you look at individual tumors, they have varying T to N. So when you're kind of using partition model, and I would argue that it is not appropriate to use one T to N for all patients. It really has to be a patient-specific calculation. And even how you compute the uptake ratio is important. We argue for you drawing the entire liver and then using that as a normal liver as opposed to dropping an ROI, because ROI dropping in different regions have also high variability. And the dose of the tumor is directly proportional to the uptake ratio times the dose of normal. So if R is not calculated with high precision, your dose estimates are going to be very imprecise. The other words you might hear in terms of dosimetry are voxel dosimetry. And what voxel dosimetry does in very simplistic sense is it uses the distribution of activity within the liver at a voxel level, at small levels, to compute the dose. And graphically, what it means is I've shown here. I've taken that same patient and I have done the 3 different models here. And you can see here's the actual distribution. Here's what the voxel doses are telling you, and which should match this. But you can go back. We clearly know that the standard single compartment MERD, it doesn't do a very good job. But you can see even the partition model, because all the tumors are lumped into one, it grossly misestimates or incorrectly estimates dose to this large tumor, because we know that was not what's delivered out here, because it doesn't have the mathematical complexity to deal with that. So it's important to know that MERD and partition model really cannot give you any spatial distribution, okay, in terms of dosimetry. And here's a study that we had done where we looked at matched VOIs for tumor and liver for about 20 patients, and we had about 40 tumors in the study. And we looked to see if I did the single compartment MERD versus partition model versus, what I say, voxel dosimetry Monte Carlo, what is the dose distributions? And we can see for the normal liver, things are pretty reasonable, okay? Things match up between normal liver and, the MERD, partition, and voxel dosimetry. But if you look at the tumor doses, right, they're quite different here, right? So even if you use matched VOIs, different models can give you different numbers. And that is very important to keep in mind. So this goes back to now, the radioembolizing community, all of us, we really need to be more specific when we report dosimetry. We really need to develop a lexicon, That's what I would argue for. We really should be not just saying I treated to 60 gray, but we need to say I treated to 60 gray using a device, what disease, and which dosimetry model did I use to the calculation. All of these things are needed to precisely characterize that statement. So it is important to know that 100 gray by single compartment MERD is not the 100 gray with partition, which is not equal to 100 gray with voxel dosimetry. And furthermore, the biological effect of dose also depends on the device, which I mean is that 100 gray treatment by Sursphere to a tumor is going to give you a different response as opposed to 100 gray with Therasphere to that same tumor. So sort of end with a summary here is that, you will see through the course that Y90 has really proven to be a very safe treatment, both for the provider and the patient, okay? But careful planning and attention to detail is critical for success. And post-therapy imaging is essential for verification of treatment delivery, obviously qualitatively and quantitatively. So, liver is clearly a radiosensitive and pathological organ here. It is the heterogeneity of the Y90 dose distribution and the short range of Y90 that makes it less radiotoxic than EBRT, external beam radiation therapy. But it also means there are differences within the different devices that they use as well. A good thing to keep in mind is that Y90 deposits about 90% of its energy within about 5 millimeters of tissue, and all that deposition takes place within 11 days. Okay, remember, it's got a 2.5-day half-life. There has been substantial progress over the past 5-10 years towards refinement of the dosimetry models. How do we actually quantify those, and in response and toxicity assessment? But standardization of dosimetry, standardization of imaging and reporting is desperately needed. And specifics on these parameters, like I mentioned before, on the device, dose, the dosimetry model, etc., is critical when reporting and interpreting clinical outcomes. So there's really an opportunity for sort of a lot of us to kind of still contribute to the field and make it better. So with that, I want to thank you for your attention.
Thank you so much, Dr. Kapadath, for that talk. That was wonderful. And next, I would like to introduce Dr. Justin Lee, who's a clinical professor at Florida Interventional Specialists. And Dr. Lee will be discussing dosing options in depth.
Well, I'm going to apologize in advance. I'm actually at my house, and this is how coronavirus things go. But the HOA has decided to mow my lawn. So if you hear a bunch of dogs or lawnmowers in the background, that's just, I guess, how it goes in the COVID world. I think it's really a privilege for me to be able to follow Chinu there, because I think the things that he talks about from a physicist standpoint, I've come around to those exact same conclusions, but from a clinical standpoint. These are my disclosures. So I've been practicing Y90 for over 10 years, and I've had the luxury of starting programs in both an academic and a private practice world. I'm currently in a private practice world. And then I've had the fortune of also being a proctor for Certex, and that's allowed me to meet a lot of the people who are on these calls, and it's allowed me to challenge myself with what my assumptions were about how I performed Y90 over the last couple of years. And I think, it's important to understand that whatever you think you were doing at one given point, say 10 years ago, might not be what is actually correct, and so dogma doesn't always follow through over time. This is going to be the only slide that I have really about the dosimetry models, and I think it's impossible to do a 15-minute talk about dosimetry and not at least mention them, but this is the way that I kind of think of them. So the MERD model really is a single compartmental model. As Chinu basically pointed out, there's no differentiation between normal liver or tumor. So I think for treatment, at least in our practice, if we were to use MERD, we would be doing it in a segmental style fashion. BSA has been around for a long time. We've been using BSA, and I think largely when we go out and we proctor, BSA is there because it doesn't require rigorous volumetric data to be obtained. And so for early programs that are doing Y90, it's something that's simple to do because you essentially calculate what volume you're going to be treating using the patient's height and weight. But unfortunately, it has major limitations because body surface area and liver volume are really only linearly correlated in patients who have normal livers. So for diseased livers, which is what we're treating, it may or may not suffice. But it's been used pretty effectively in the trials that Riyadh talked about, Foxfire and Sarah, for lobar dosimetry with multiple tumors in a given lobe. Partition is another step, and it's gotten a bad reputation because it does require a little bit more rigor in terms of calculating volumes, and the volumes are extremely sensitive and adjust your activities just with small differences, and so you have to be able to do it accurately. In addition, it has this variable of the TN ratio, which really will adjust activity, and that TN ratio is based on the MAA, and as we know, the MAA uptake can be variable because it's not the same as as the Y90 sphere. But I use that in my practice for both lobar and segmental treatments. I think, though, to summarize everything, where we've had stumbling blocks over the last decade has really been that we've been trying to obtain reproducible outcomes with variable methodologies. So people would consider themselves either a glass user or a resin user. And even within the sex of glass and resin, people do different things. So I've been to places where people say, well, we tried to achieve a background delivered dose of 50 gray for all patients, or places where we tried to achieve a lower background dose. And unfortunately, when we have that type of heterogeneity in how we practice, we get different outcomes. I think the challenge that we have is that we really need to maintain a focus on controlling the outcomes that we know we can get, which is toxicity. So up on the top left, I've got a patient with radiation-induced liver dysfunction with the sequelae of a shrunken liver and ascites. And then what I have on the right is a patient that is one of my patients, which is really RALD in a controlled manner. So this is a radiation segmentectomy. So obviously, one is something that we want to get, the other is something that we don't want to get. And we do know that we can avoid that outcome when we do good practices. So this is how I kind of break it down to the 4 pillars of dosimetry, or for lack of a better word, how one might put all of the things that Chinu was talking about together into coming up with an activity. And I agree with him that we use the word dose and activity interchangeably, and that's not really correct. So the concepts, and I'm just going to skip this really quickly, is that, absorbed dose is an energy imparted to the tissue, and activity is a measure of nuclear transformations that happen per second. But so when you're using the concept of, well, I gave this tumor X amount of dose, 120 gray or 400 gray or 60 gray, that's not the same thing as doing activity. And you really don't get a chance to control absorbed dose. You control the activity because you tell your nuclear medicine people or whoever's drawing up the dose, or in the case of glass, whatever vial you're going to order and decay it to, you're controlling the activity, but really you don't have much influence over the absorbed dose. And the reason for this is this drawing that was already shown by Chinu in his talk, which is that the isotope, in terms of its effective radiation, is actually really centered along the isotope. And as we get further and further away, we're really getting insignificant amounts of radiation. And why that matters, this is a picture from Andy Kennedy early on, is that we really need these clusters to be together, because we can have cold spots where we don't have clusters of beads, and we can have relative hot spots where we do have clusters of disease. And anywhere where we don't have spheres, we're going to end up getting, we're going to get failures in our treatment. So I think, what I've felt is that people feel that this is the ideal scenario, and a lot of people assume this is what happens when you have a tumor. You get the beads that uniformly distribute throughout the tumor tissue with their spheres of radiation that are overlapping. But in clinical practice, that's not what actually occurs. This is one of a patient that I actually treated with a pathology specimen that shows the clusters of the spheres. Some of them look linear, like as if they're following vascular channels. Some of them are in probably bigger vasculature. But here you can see this red line. These are tumor cells that are still viable, and there are no spheres, or there may be 1 or 2 spheres sitting over in that side of it. And so we don't get death. So I contrast the ideal scenario with the reality, which are these clusters, lumps, single spheres, and then what we really don't want, which is many spheres outside the tumor. Interestingly, and Armin's group at MD Anderson and some people on the glass side have done some work looking at microdosimetry, where we can actually predict that the spheres do form reliable cluster sizes, and it is related to the number of spheres that we use. So I call Y90 kind of the biggest game of Plinko, because as Chinu just kind of said in his talk, distribution is king. So absorbed dose is really a function of distribution, and tumor response is very sensitive to coverage. So the trick is, how do you get the Plinko bead to land in the tumor and to not land outside the tumor in the liver? What I think has happened in the literature over the last, say, 5 years is that we've addressed increases in target dose, or really activity, as a response to the fact that we don't have a control over distribution. So how do we really control distribution? Well, we increase the number of spheres that we put out there. The problem is that when we do this arbitrarily, we're sure to fall into cases where we're also going to increase toxicity. I do think, as it's been said multiple times here, that you can have a better understanding of what the distribution is like when you use cone beam CT. And I've changed my practice since when we started around 2006, that really liver sparing or segmentectomy should be favored over lobar treatment. And that is even true for patients who have bilobar disease. And really, we can look back into the early 2000s to see explant specimens from Andrew Kennedy, as well as this paper in 2001 that looked at patients who had their tumors either resected or biopsied after treatment. And they found that basically the beads would cluster into these areas. And in these areas, if you drew isodose lines, and these were estimations at the time, you could see very high doses if you were close to the beads. And the farther you got away, you had very low doses. There's a very interesting paper that was published last year using glass that looked at this specific concept in a pig model. And what they did was they gave doses of glass in different days with obviously increasing number of spheres. And what ends up happening is kind of linear increases in what you would expect. So if you look at the bar graph over here, the clusters per ml of tissue go up as the number of beads go up. So this decay is increasing number of beads. The distance between the clusters ends up going down. So essentially the way that I like to think of it, and I think this drawing really shows it very well, is that you get dose homogeneity as you go up in the number of beads. So this is kind of a surrogate for distribution. As you distribute more evenly over tissue, you get better homogeneity of dose. Versus when you have smaller groups of spheres, you end up getting pockets with very high radiation, but gaps where there isn't high radiation. So, as much as there was some discussion and allusion to whether or not you could get rid of the mapping procedure, I still think it's the cornerstone right now for how we can predict how our dosimetry is going to look. And so I think there have been a couple things that have been shown in the literature that are really key points. Number one is SPECT. The use of SPECT CT is superior to planar imaging, and I think it should be the standard. Ironically, I didn't have SPECT CT when I was in an academic setting, and in a private setting, I do have it. One of the challenges that we have in a private setting is that it does not get reimbursed. Another thing to understand is that your lung shunt fraction is actually a critical thing. I do agree that in metastatic disease and in small HCCs, the lung shunt fraction really doesn't participate that much. But when you are looking at lung shunt, you have to understand how it's obtained and how the fact that you have attenuation can actually underestimate or overestimate what your shunt fraction is. In addition, as pointed out, everybody sort of uses this 1 kg model for the lungs. The volume of the lung tissue, though, can change, and as volume changes, so does your dose to the lung. I get asked about this all the time, the TN ratio. So if you're using the partition method, what are you using for your TN ratio? And I will admit that I don't actually currently have the ability to measure the TN ratio in real time when I do my mapping. But you can look back to the 90s to look at how variable the TN ratio is and why we need to come up with better means to measure it. A TN ratio that's less than 1 actually means more of the spheres are going to be distributed to normal liver than they are going to be to the tumor. And look at how wide the variation is in HCC versus metastatic disease, which I think just goes to the bizarre nature of the vascularity of these HCCs. Switching a little bit to time as a factor in how we do things. It became really a point for me when I would proctor and I'd ask people, when did your dose show up? What type of dose were we using? And, a lot of people would say, well, they didn't really know. And a lot of people don't understand that, if your institution makes an assumption that, okay, it's better to have the dose available so we know it's there, well, it's actually decaying for you. So you're actually getting a less potent, for lack of a better word, sphere the more that you wait. And the two different products actually overlap somewhere here in the middle. So glass beads have a calibration time that starts at about 2,500 becquerel per sphere, and that decays over time. And we use the product somewhere within this time period. Resin now with its flex dosing options intersects it, so you can get a shipment of the vial early on in that pre-calibration period, where your beads will actually be more hot than it's for you to use it closer to your calibration time. And really, there's no strong scientific evidence that supports where this should be done. I mean, we see people who use extended shelf life glass in a lot of papers that are published, and then we see people, for example, like Armin, who might comment on this later, but they have a tendency to use the earlier 3-day pre-calibrated doses of resin in all of their cases. Just to put this into kind of graphical form, so this is how we use glass in our institution. Usually it's for smaller lesions 200 centimeters or less, and we're looking for a target dose somewhere around 200 to 300 gray. And so the
It looks like we may have lost Dr. Lee's connection.
I don't know what happened there. I'm terribly sorry. Can you see me now?
Yes, Dr. Lee.
And you can hear me? All right, I'm just to move on, just to understand that when we're using glass decays, and it's sent to you it's sent to you calibrated, and what you're doing is you're decaying it until you use it. So a lot of people, I don't think understand this, but that if you order a 20 GBQ vial, you may be using it when it actually only has 1 GBQ or 1.5 GBQ in the vial. And so that's one way where you can kind of play the game of saying, okay, well, if I want to have a more embolic glass dose, what I can do is I can fall it out on the decay curve and use it later and later. The slide that I had before this was just showing how we use glass. If we want to obtain a higher dose for a smaller particle count, we may use a 3 GBQ vial, but we're going to use it earlier in the decay so that way each sphere is hotter. It's a little different for resin. So resin is actually shipped pre-calibration, not post-calibration. So that's why they call the flex dosing a pre-calibrated dose. So you may have a 3-day pre-cal, 2-day pre-cal, or 1-day pre-cal. What I was alluding to before was it's interesting that sometimes you show up and people don't know what they have. And so early on when I was doing segmentectomy style dosimetry with resin, I was always using a 1-day pre-cal because I would use it on the day that it showed up. And people that I was proctoring were proctoring actually using a post-cal or a day of calibration vial. And so that's just going to be a more embolic vial. And so it makes it a little bit harder. And what's interesting is that the number of spheres per given activity goes up about 20% between each one of these vials. So what does that look like for your nuclear med people who are drawing things up? If you have about a 44 million sphere count vial, if you pull 1 GBQ from a 3 pre-cal vial, which is about 7.2 GBQ, you're going to be getting about 6 million spheres. If you wait all the way to the day of calibration, what's going to end up happening is you're pulling from a 3.3 GBQ vial. Same 44 million spheres, but what you see when you pull 1 GBQ, you're getting yourself about 14 million spheres. And so that difference is a huge difference between the two different products. And this is what can happen. This is a case applied to be my Mitch-Ehrman trout, but you can see if you have something where you don't have enough embolic to get coverage, what you can see on a Bremstrong study is areas of very high dose uptake and areas of very low dose uptake, and sure enough, those are areas where you get recurrent tumor. And this has been shown in the literature, just to try to go fast here. This was a trial looking at HCC, BCLC-B, and C patients who received resin radioembolization. And just looking at this progression-free survival curve and Kaplan-Meier curve, what you see here is patients who got high dose versus low dose, defined by reaching a threshold of 100 gray, those patients had a response. But whether or not you had high dose or low dose and you didn't target the tumor, you had terrible progression-free survival numbers. I have to talk about target dose, and this is very, it's very interesting stuff right now. It's coming out. This is a Dosisphere trial, which, which really looked at standard dosimetry for glass versus a personalized multi-compartment dosimetry with a target goal of reaching above 205 gray or attempting to reach that 250 to 300 gray threshold. The interesting thing to look at is that these are large tumors. So one of the questions is how do they account for coverage in tumors that on average are about 10 centimeters? And if you kind of pull that over and look at the activities, you see that the activities are very high. Now you can achieve very high activities per vial if you use them early in the decay of a glass vial, but then you may be losing the number of particles that you need in order to address a tumor that's 10 centimeters. So my guess is that multiple vials were used. And this is kind of from their Kaplan-Meier survival curves, which are very encouraging. You can see patients who have very large tumors, getting survivals out, beyond 2 years. What I think is interesting from the trial is that the early trials, like Riyadh's early trial on the Premier trial, kind of really the first HCC randomized trial for Y90, had a time to progression that was very acceptable at 26 months using much lower target doses. And what I think what we're seeing there is a difference between large tumors and small tumors, that you obviously have to account for larger tumors, meaning you need more activity in order to address the coverage issue. And this was again shown, this is a subset analysis in the SARA trial where they extracted patients and they looked at these patients using a non-voxel-based dosimetry computation, but essentially found that patients who had received over 100 gray plus had distribution that matched the MAA scan ended up having survivals that were very equivalent to the Dososphere trial. So quickly, just some cases. This is just one small HCC where we use cone beam CT to know exactly the volume that we're treating. Here what we use is a target dose based on the background liver dose of 50 gray because we're willing to throw the baby out with the bathwater here. The activity was about 1.2 GBQ and we used a 3-day flex dose, achieving a target, or at least trying to achieve a target dose of 340 gray. This is kind of like from the SARA trial. This is one where coverage matters. Portal vein invasion, big tumor, looks very ugly. Unfortunately, dosimetry really here is limited by lung shunt. This is why I would say I still think the lung shunt is important for big tumors. Here we made the right lobe and the left lobe equivalent. We used 120 gray threshold with a flex dose of 5.6. And we actually put the patient through dosimetry-based software, where you can see our D max was somewhere around 255. Our D mean was about 173 gray. And we had a great response. This patient ended up going on to resection after receiving Harvoni for her Hep C. Lastly, segmental high target doses. Basically, again, this is sort of similar to the other case that I showed, but here again, we're targeting instead a background liver dose of around 70 gray, which gives us a calculated activity about 1 GBQ. When we put that through our dosimetry, our voxel dosimetry software, what we see is that even with 1 GBQ of activity, when we're administering it in a very tight distribution, we can get doses as high as 400, over 400 gray. Obviously, this is for smaller tumors, and again, it goes to speak to the fact that distribution is really important in terms of target dose. So sorry about getting disconnected, sorry about kind of being over, but to cram all this stuff into 15 minutes is very difficult to do. My summary really is that dose is a multifactorial thing that really depends on time, volume, tumor type, and what your outcomes are going to, or what your objectives are going to be. I think given the physical principle of Y90, we have to focus on distribution, which means you have to talk about coverage, and you have to make a decision. Do you need more point sources, i.e. more beads, or do you need more activity for the different treatments that you're trying to do? I think coverage can be controlled by paying attention to the decay curves, and so what you're trying to use, as well as your MAA mapping. And really now, I mean, we've seen now multiple examples of voxel-based dosimetry software. I think that's going to become the new standard. It's going to help us get better outcomes for our treatment. So that's it. Thank you very much. I apologize for the internet snafu.
Thanks, Justin. That was a great talk. So next up is my talk. I'm just going to share my screen here. Okay, so my talk is on optimizing tumor coverage. These are my disclosures. And so you've already heard some of this, which means that I can probably skip some of this so we can make up time. But the premise of this talk is that, as you've heard, the beta minus particle, which is a product of the radioactive decay of Y90, that is the actual entity that kills the tumor cells, doesn't travel very far from the sphere wherever it's deposited. The average is about 2.5 millimeters and the maximum 11 millimeters. And so one of the weaknesses or the limitations of Y90 is adequate tumor coverage, as it is with every embolotherapy, but in this particular instance, it's about the beta minus particle. And so, oops, let me go forwards. And so, and Justin's already talked about this, about like adequately covering the tumor with what we call radiation clouds. If you think of where the beads deposit inside the tumor, or the spheres deposit inside the tumor, then you want enough spheres that you have the beta minus particles, which form a radiation cloud as they travel away from the sphere, to cover all of the tumor. So you don't want, so in the ideal situation in a 3D model, you would have complete coverage of the tumor with radiation cloud, so that you don't get this scenario, which you already saw this diagram, where you have uncovered tumor, which is the areas that are in between the green, that are outside the radiation cloud, because these tumor cells will survive and then grow, and you'll have residual tumor or recurrence. And so, and the problem actually lies in the fact that the bead distribution, as you've already heard, is very, very heterogeneous, which has been shown in pathologic specimens And so you can see here, and this was a resected specimen. They looked at glass and resin specimens, and they found that predominantly the beads, this was Andy Kennedy's paper from 2004, deposited in the periphery of the tumor in clusters, regardless of which product you used, and that the dose maps, if you looked at the dose versus the bead distribution, was very heterogeneous. And then this is another paper where they they resected a specimen that was treated with Y90 10 days after the Y90 treatment, and they performed an autoradiograph, which is basically an X-ray looking at the deposition of radioactivity, which is the picture in the middle, the B picture. And you can see, obviously there's large photopenic areas that correspond with intratumoral central scarring. But then if you look, for example, on the bottom right, you can see how heterogeneous the radiation distribution is, which corresponds to very heterogeneous dose distribution, which is the bottom picture in blue. And so how much control do we have over the distribution of spheres, in the tumor? So the factors to consider that contribute to the heterogeneous distribution of spheres is knowing the number of spheres required for adequate tumor coverage, the flow dynamics in the liver, which is variable in different patients. And then also there's areas of perfusional variation in the tumor. Some areas are more hypervascular, some are a bit less vascular, some areas have necrosis or fibrous tissue or cystic change. And so some of these factors we do have some control over, not complete control. So we can control the number of spheres required for tumor coverage, and we have some ability to alter the flow dynamics in the liver. We just can't alter the perfusional variation in the tumor. So in terms of the number of spheres, it's important just to be aware of the number of spheres you're delivering, because there's lots of different options with both resin and glass beads. With resin, as you hopefully are aware, for resin users, there is a flex dosing now, and I strongly encourage you to use this. Before, usually you would get one dose that would be delivered. In our institution, it turned out to be a one-day pre-cal sort of use that we used. And as Justin said, some people were using it on the day of calibration. And so you'd have a lot of spheres. Now there's a flex dosing where you can get the same dose but delivered, or the same activity vial but delivered and used earlier. So here you can see that there, for a 1 GBQ dose, depending on when you use the vial, you can either have 13 million, 10 million, 8 million, or 6 million spheres. And so that allows you to do more and achieve segmental deliveries easier. And then glass has always had a wide range of sphere numbers available, from 1.2 million to 8 million, depending on the activity vial, and then anything in between, including the custom doses. And so it's important to think about the number of spheres that you're delivering, because you have multiple options. With resin, obviously you can deliver any time of any day. With glass, you have to, there is a bit of a restriction and if your schedule's flexible, then it doesn't matter, because you can deliver hopefully any day that your schedule allows, and you can get the right number of spheres. I'm just going to skip over this part here and then just talk about, so how do you estimate the number of spheres required? Because there really is no magic formula. So you just have to take factors into account, like the tumor volume, your overall treatment volume, and then the type of dose that you want. Do you want a tumoricidal dose where you're just looking to kill the tumor but spare the surrounding parenchyma, or are you looking for an ablative dose where you ablate the tumor and the area around the tumor, which is a segmentectomy? And then the other things to consider are the tumor vascularity, which we can, when we're calculating or estimating that, we estimate the T to N ratio. And so taking all these factors into account, you can think about the number of spheres that you need. And often I sort of look at it pretty like simplistically. Do I need a little amount of spheres for a small segmental delivery, a moderate amount of spheres, or a large amount of spheres, depending if I have large multifocal disease or a really large tumor, and then I try and tailor the number of spheres accordingly. So I'm not going to talk too much more about that, because I personally think it's a bit of a dry topic. I think the more interesting topic is the flow dynamics and how we can alter the flow dynamics in the liver. So there's two ways we can alter the flow dynamics to some degree. Firstly, extrahepatic flow redistribution, and then intrahepatic flow redistribution. I'm not going to talk about extrahepatic flow redistribution because I think most people are familiar with that. The idea that if there's an extrahepatic artery supplying the tumor, classically it's a phrenic artery, then you can embolize that artery with some sort of bland type device. You can use spheres and coils. And then the area that artery is supplied by will then start to be supplied by the intrahepatic arteries. And so when you deliver from the intrahepatic side, you should be covering that area of tumor. Intrahepatic flow redistribution is something that I think is, it's kind of variably used. It's possibly underutilized, where we can alter the flow dynamics from inside the liver. And there's multiple techniques that we can use. So one is to embolize the intrahepatic branches to consolidate flow towards the tumor with plugs or coils. I don't recommend it. I think most of us would not do that, because then you've permanently blocked your inroad if you ever need to retreat or treat another tumor, since these are often patients typically have multifocal pathology. Then you can use a temporary occlusion device to occlude distal branches and non-tumoral branches to direct flow towards the tumor, which I'll talk about in a bit more detail. And then there's pressure-directed embolization with an anti-reflux catheter that's been briefly touched on in Shui's talk as well. So I think the second two are worth talking about. The first one, I think there is literature on it, but I just personally, most of us probably wouldn't recommend permanently blocking an intrahepatic artery. So in terms of temporary occlusion of distal branches, the idea is that to temporarily occlude, if distal to where you're delivering there is a major non-tumoral branch that would inevitably take up a lot of beads, while there's other branches distal to the catheter tip that are tumoral branches, then you can temporarily occlude that non-tumoral branch, either with a recapturable plug, a balloon catheter, or a resorbable agent like gel foam or degradable microspheres. And the idea is to promote flow towards flow of spheres towards the tumor, and then also to protect that distal branch from non-target embolization. So I'll just show some cases. This is the case of my colleagues, which I like because the pictures are really nice. 59-year-old male with cholangiocarcinoma that was unresectable and was progressing on chemotherapy. So you can see the big centrally necrotic mass in segment 6. And then, so this is a non-selective angiogram, and you can see here the tumoral vascularity with the central area of necrosis. So on the left-hand side is a non-selective angiogram. This arrow is pointing to a segment 7 branch, which is the branch that's been catheterized with the microcatheter on the right, which was a non-tumoral but very prominent segment branch supplying segment 7 and not supplying the tumor, whereas all these other little branches just proximal to it were supplying the tumor. And so what you can do here is, there's actually an MVP plug that has not been detached sitting up here in there. And the way we use this technique is called the double catheter technique. And so the idea is that you put in a catheter such as typically a guiding catheter. You can use a sheath, and through it you put 2 microcatheters. One is going to be your delivery microcatheter, and the other one is the one that you put the plug in, but you don't detach the plug, and you temporarily occlude the branch that you want to occlude. And so this is that's the plug there, and this is pre-delivery. You can see this is just a late angiogram where you can see that there is no flow up in segment 7, and there's good blush in the tumor. So then you deliver the spheres from the proximal microcatheter, and then at the end of the procedure, you recapture the plug, and then you remove both microcatheters using proper radiation precautions. And then this is the post imaging showing the tumor on the left, and then the BREM scan showing uptake in the tumor. And then in the non-tumoral areas of segment 7, there's very little uptake. There's often some uptake still, because once you temporarily occlude the branch, then there will be some collateral flow to that area that was supplied otherwise. And so you will get some uptake often, but it's much less than if that branch wasn't occluded. This is another case that I did. This is a 55-year-old male with a HCC at the junction of segment 3 and 4B. He had a left hepatic artery coming off the left gastric artery. So here is a selective angiogram, and you can see that there's tumor blush coming off the sort of central aspect of the artery to segment 3 here. And by the way, this is a chemoembolization case, but the principle still applies. It's just, again, the pictures are really nice, so I just wanted to show, because the exact same principle applies to Y90. So the problem is that these multiple tiny wispy branches coming off centrally here from the left hepatic artery or from the lateral segment artery were supplying the tumor. And I actually started to taste them just to see what happened. And the chemoembolic mixture just went straight down into segment 3, before it was filling the tumor. And I was just kind of wasting it down there. So then what I did was the double catheter technique and put an occlusion balloon in. So here is my the guide cath, and then there's 2 microcatheters, one which is going to be my delivery microcatheter, and then there's a temporary occlusion balloon here. This was a sniper balloon, and so with the sniper balloon inflated, the patient wasn't holding his breath, but you can see here that with the balloon inflated, there's good flow into the tumor and little flow peripherally into segment 3. So then I embolize from the proximal microcatheter with the balloon up. You can see good staining here, good staining of the tumor with relative sparing of the peripheral aspect of segment 3. And then the tumor was completely necrotic, and he has actually had no recurrence. It's been beyond 15 months now. Then there's literature. There are case series on this showing how that this can be effective, yeah, there's not a lot of literature, but there are some good case series on it. And then the other concept of enhancing tumor coverage is pressure-directed flow, which was already touched on earlier. And the idea is to use an anti-reflux catheter, such as the Surefire catheter or a balloon catheter, that creates a pressure gradient distal to the catheter tip, and also does what it was intended to do originally, which is to prevent reflux of embolic agent. Now, we don't really utilize this in my institution. Like, we're sort of still kind of experimenting with it. I don't have any wonderful cases to show you, but the principle is this. So, and this picture was taken off one of the manufacturer's websites. So if you inject in the left image with a standard microcatheter, a standard end-hole catheter, then the flow is just directed by, the particles just go to the tumor via just whichever way the flow is going, with uniform blood pressure throughout the whole arterial tree. And so some particles will go into the tumor, some will go into other branches. If you inflate a balloon or you use a Surefire catheter, some microvalve infusion catheter, then it significantly decreases the pressure distal to that catheter. And so there's systemic blood pressure proximal to the balloon, and then significantly lower pressure, which has been proven in vivo and in vitro experiments. Then what happens is you've now occluded the main inflow to the tumor. And so if there's enough collateral flow to the tumor, so it does depend on the degree of collateral flow, then it will reverse flow in the other branches towards the tumor. So when you deliver your embolic agent, it will preferentially go into the tumor and not into those other branches, which now have retrograde flow. There is some literature on this. There's not a lot. Most of it's done in the setting of TACE. This was one of the studies that I like, and they looked at, there were 70 patients with an end-hole catheter. It was a Renegade catheter, and 18 of those patients got a liver transplant, and then 18 patients with the Surefire catheter, 5 of who got a liver transplant. The mean tumor size in both groups was 3.1 centimeters, so they weren't large tumors either. And what they found was in the anti-reflux catheter group, there was statistically significantly better objective response by mRECIST, although no difference in the local progression rate later. There was a better reduction in AFP, not at 1 month, but at 3 months. And they also found on histopathology of those patients that got a liver transplant that there was better on-target bead distribution inside the tumor versus the parenchyma surrounding the tumor. And also there was a higher percent of tumor necrosis on explant pathology in the patients that had the anti-reflux catheter used. So in conclusion, the average penetration of the beta minus particle is only 2.5 millimeters in tumor. And so the adequate coverage of tumor by spheres is important, not just looking at the activity or the dose that you're delivering. For a given activity, remember that you can choose from different sphere volumes for both resin and glass and tailor the number of spheres to the target tumor and tissue. And then there are techniques to direct more flow and therefore more spheres towards the tumor that can enhance tumor coverage. And that's it.
Thanks, Donna. Appreciate the presentation. And I just want to make sure Armin, Sabina, Eddie, I see Shui's there, Chinu, I see Justin, and of course Donna stay for panelists. We have about 13 minutes or so for some discussion before we break for lunch. And Alan asked some questions that I think I'm going to address to Armin and Chinu, please. That has to do with the various voxel-based dosimetry software options. Can you describe, I know you guys are pioneering that stuff, Chinu or Armin, what are you guys doing with the voxel dosimetry, and discuss that software, please?
I can speak to it from the clinical use, I guess, and
sure.
So I'll just speak to it from what we're using. And obviously, Chinu can talk about the algorithms I use because I don't honestly know. So we've used both in recent history. We've both used Simplicity as well as MIM AssurePlan, and so we are actually using both pieces of software for our prospective trial right now. And so I will tell you, just from a user standpoint, as the IR using it, there's a learning curve with all the software. Honestly, like I remember when I first started using MIM like 5 or 6 years ago, it would take me an hour to contour a case, and now I can do it in about 10 to 15 minutes, start to finish. So clearly, like there's a learning curve. Using Simplicity, that was the same thing when I first started using Simplicity. It took me longer, but now it's much quicker. They all have their, they're similar in what they're doing. Obviously, you're contouring the liver and the tumor, and they have lots of tools to facilitate that for you. There's AI algorithms to auto contour for you to help you contour the tumors. Clearly there's no, not one piece of software is better than the other. I'll just tell you, like, you haven't used the two most like frequently used ones. It's just a matter of finding one that you're comfortable with and using it, and get comfortable with it, and then you'll obviously like become more facile with using it over time.
Chinu?
So I want to just add that, in terms of dosimetry, they pretty much, all of them do the dose calculations. The nuances come in. Some of them can create these RT struts that if you're dealing with a radiation oncology colleague and you want to transfer some of your contours, those are where the nuances come in. Some allow that feature, some don't allow the feature. But I think you have to remember that the software is only as good as the user. These will require segmentation and contouring to kind of figure out what the tumor doses are. And so, getting the software is important, but actually spending some time and, figuring out how to use it and actually contouring is really what makes it successful. Just having a software is not going to suddenly make your dosimetry program great.
Can I ask Justin or Shui, are you guys using any of that software? Because you guys show some pretty sophisticated dosimetry stuff. Are you using software, Justin or Shui?
Yeah, I actually, being in private practice, I had a little bit of a different experience. I just cold called MIM and Varian, and the computer that I'm currently on actually has both of them on there, and I've been using it myself. I'd say I just want to add a few things. You have to make sure that that your cameras are calibrated. So we're not doing Y90 PET because we don't have a PET scanner in the area where we do Y90. So we're doing a BREM SPECT CT and putting it through the software. I agree they're all kind of the same, and it really depends on your institution, what you're going to buy, what you're going to use, but they all require a good deal of time to make them happen. So that was why I was fortunate enough to get it on my computer. I've spent hours, playing around with it. The other thing too is that they all use deformable registration. So what's nice about it is you can actually take a scan that was done, way in advance and overlay it to the treatment, and it'll look a little funky, but it will force things to overlap. So I think for where we move in the future is going to be, I guess number one, can your institution get paid for it? But number two, can we start to use it in lieu of like the other volumetric stuff that we were using, for example, like Terra Recon, which we were doing. So that's kind of where we've put it in there, but it's really been, kind of my pushing it along. I think if you don't have that, then your hospital's going to be wary to go buy it because they are about 40 grand a piece.
And Shui?
Yeah, no, I think what I can speak to, unfortunately, I'm not using it, and partly because anything new takes a lot of effort, and this kind of process, you need IT involved because you're getting images, and then they have to get sent to the software. And Justin brings up a good point. I want to ask the other people who are using it is reimbursement, because when we had our business plan for why we're going to start doing scans, because actually we weren't doing any post Y90 scans after a while, we actually weren't. So it's again building in a new process. And part of that plan was getting reimbursement. I know there's been mixed messages on that. So I actually want to ask, is anyone getting reimbursed for advanced dosimetry, the post Y90 images, or even the PET scan that you do? Are you getting reimbursed for that? Because that was a big question mark for me.
Justin, you want to go
the United States? I'm sorry.
Yeah, well, so I think, because I was very fortunate to start the Y90 program at Sarasota Memorial, which is a big public hospital with a huge foundation because of the community. So we were just doing them. Our believe it or not, our nuclear medicine is built out of cardiology, so that's another even challenge to do. From a value proposition, they were doing it for me basically for free, these SPECT BREM scans. I went to them with the software and I said, well, here's the ability for you to get paid. And my understanding on the CPT code, it's about $1,200, which is a code that the institution would be able to bill, not the IR. I think the reimbursement for us is still like around $200 to do it. What you have to be able to produce is the dose plan. So it's a nice piece of paper that has, for example, with Varians, it's the GTV, which is your tumor volume, and it tells you kind of the dose breakdown, et cetera, et cetera. But it's a Medicare thing where you have to have that produced in order to get that paid. Secondly, and this is just another sort of thing out there, a big issue with the hospital was, what visit are you charging that on, right? So you can actually do this, the next day. You could technically bring the patient back if you wanted to do the PET the next day. Our hospital we've had a lot of revenue cycle meetings about this, because it's not just like, oh, you do it and it gets billed. We actually had to force a 120-day trial period to make sure that we would get paid by the insurers before the hospital would really bite on doing it. And then to just one last point, when you're doing it, you start to separate yourself from your RADONC. So if you work in a 2-doctor model and you start doing it, it's like, well, who's going to do the billing? Now, what I've done is I've said, let the physicist that's owned by the hospital do it. The $200 is not really worth it to our practice. The time doing it is not. I want to get the data, because to me, the data makes more robust tumor board conversation, et cetera, et cetera. But all those different things have to be worked out. These were all snake pits that I fell into and didn't quite realize would happen when a year ago I said, hey, there's this new software out there and it's really cool and we should use it.
I can speak intimately to the PET CTs if you like, Riyadh.
Yeah, go ahead, Eddie.
All right. So in my facility, I don't have SPECT CT. I only have PET CT. So that's a primary driver for why I do that. But, in our state, at least, several insurance companies will pay for the post-procedure PET CT. I will tell you that there are certainly some that don't. I've spent more peer-to-peer time dealing with post-Y90 PET CTs than I have anything else. So I have a lot of experience dealing with it. Usually it'll get approved, but it can be a rather painful process. The insurance companies seem to want to pay for like an eye to thigh with FDG, but they don't want to pay for a limited abdomen PET CT, which is what we do. So kind of to offset those costs, I do the dose volume histograms on a lot of these patients that are kind of on the easier side to say, because it's essentially what the RADONCs submit to get reimbursed. So I can do that, and I do it all within the MIM software. It takes 15 minutes to do the pre-procedure dose, calculations and volumes, and then I just push that to, overmap or overlay with my PET CT. Takes me another 15, 30 minutes to pop out a DVH, and those will get reimbursed.
So just a couple of things. We only have a few minutes left, but a couple of people are trying to spice up the discussions prematurely from this afternoon. Joe Giametti from Michigan is asking, what is the role of SBRT for tumors in the liver? This is a multidisciplinary setting. I'm going to say no. Joe, you tell me the role of SBRT. We'll talk about that this afternoon. Joe, hopefully you'll be there. And Amar wants to talk about if we minimize normal parenchymal exposure with Y90 by selective injections, why do we do multi-compartment dosimetry if everything's going more and more selective? And that's something I think we'll be able to talk about. That comes from Amar. So we only have a couple of minutes. I'm going to save those two questions for the tumor board this afternoon. But context is important. You guys all talked about dosimetry and what you do in your practice and OBLs. Can you guys tell me which one of you guys, how many of you guys are the authorized user, the AU? Just for the audience, as a master class. Shui, are you the AU at your center?
Yes, I am. And, I'm I don't know if any non-IRs are on the call, but basically I'm a big proponent of us being the authorized user. I think we have all the training and we should be doing it. Sorry.
I agree. Armin, are you the AU?
We are not. And that's the internal politics at Anderson. And I will never be the AU.
The ivory tower. Okay. Justin?
I'm the AU, and what I can say is that when I initially moved into private practice from Georgetown, you know, I didn't understand that really radiation oncologists don't want to come to the hospital because it's just, you know, they can't, it just kills their model. So I think this is a real stopping block to people who graduate and they go out. If they're not prepared to be the AU, they're going to have trouble getting their Y90 program off the ground.
So for the audience members, what Justin's talking about is that much of the rad-onc practice is outpatient centers and not necessarily centered in the hospital, which makes their availability in the hospital 1 day a week, if that, which means you have to do your treatments on those days if they are the AU. So Justin's absolutely right. You have to work to become authorized user if you are not. Eddie, are you the AU?
I am.
You are the AU. Did you have any challenges becoming the AU?
Actually, it was fairly simple. After I finished fellowship and started my job, you know, I got with we only use Surtex in our facility, but you know they helped me through the whole process, and it was pretty painless.
And Donna?
No, we when I work in an academic center, our nuke med guys are the AUs for us.
So Donna, just since nuke med guys are your AUs, does that mean you guys sit down together to do the dosimetry, or you email them information? How does that work?
So we calculate the dose ourselves.
Oh, so I'm sorry. So you're doing all the work. They're just signing the paperwork.
Yeah.
So you're effectively the AU, except not on paper.
It's not on paper. Yeah, correct.
Okay. So you're the practical AU. Chinu, just Sabina. Sorry, Sabina. How about you?
All the IRs are AUs.
That's fantastic. Did I get everybody in the panel? Eddie, Sabina, Armin, great. So it is now 11 o'clock. This was a great morning. Thank you, everyone. We are going to break now for 2 hours for lunch break. Please come back this afternoon. We have more HCC, and we're going to have tumor boards where we're going to challenge everybody to make decisions and tell us why they do one thing versus another. It tends to be the spicier sessions of these meetings. So we'll see you in 2 hours wherever you are. Thank you for everyone. Thank you.